A very good morning to one and all. First of all, apologies for the delay. I am Dr. Rosna Anko, Senior Resident, Department of Community Medicine. On behalf of Department of Community Medicine, I welcome each and every one of you to this multidisciplinary hybrid CME on rabies, rethink modern solutions to an age-old threat. 6th July is celebrated as World Zoonosis Day in honor of Louis Pasteur, who administered the first successful rabies vaccine on July 6, 1885. To commemorate this day, July 6th is celebrated as World Zoonosis Day. This day is dedicated to raising awareness about zoonotic disease and promoting preventive and control measures. On this day, let's all take a pledge to prevent zoonotic diseases and promote One Health: healthy humans, healthy environment, and healthy animals. On this note, let's begin today's CME, Rabies, Rethink Modern Solutions to an Age-Old Threat. To begin with, I call upon Dr. Swati Deshpande, Associate Professor, Department of Community Medicine, Seth GS, to deliver the welcome address.
Thank you, Dr. Rosna. I welcome you all for this multidisciplinary CME on rabies. This has been since long time, and we had in mind for this multidisciplinary CME. I thank our HOD sir for giving me this opportunity to give the welcome address. I would like to welcome our esteemed dignitaries for this CME, and we have other eminent speakers too. On the dais, seated on the dais, our respected Dean Madam, Dr. Sangeeta Rawat, who is the backbone behind all the programs in KEM. Madam, I request our HOD sir, Dr. Vijay Kumar Singh, to welcome our Dean Madam. Next, seated on the dais, we have our own HOD sir, Dr. Vijay Kumar Singh. He is the support behind all our programs, and I request our senior faculty, Dr. YB Savan sir, to welcome our HOD sir. Our next dignitary on the dais is Dr. Chaya Kumar Madam, who is a professor and head of Department of Microbiology in our institute, and she is also one of our esteemed speakers today for this CME. I request our HOD sir to welcome Dr. Chaya Madam. HOD sir is also the organizing chairperson of this CME, and we have our organizing secretary as Dr. Amit Bondwe. Amit Bondwe is assistant professor in our department. So I request Supriya to welcome Amit sir. Thank you. Now, there are other speakers too in this seminar, in the CME, and sitting right in the forefront is our own faculty, Dr. Deepika Sadawate, who is also speaker in our CME. She's the assistant professor in our department. So I request, I request Dr. Shweta to welcome Dr. Deepika ma'am. We have so please come.
कौन है ये? कौन है? मेरा तो बैठा का है।
We welcome Dr. Mohan Desai, who is a professor and head of Department of Orthopedics, and he is our beloved medical superintendent, and we welcome you, sir. I request our HOD sir to welcome Dr. Mohan Desai.
Student of the people professional.
Now we have a senior faculty from our department, Dr. Mrudula Solanki, who needs no introduction, of course. I request Dr. Shweta to welcome Mrudula Solanki, madam. She is the professor additional in our department. We also have Dr. YB sir, who also needs no introduction. So Dr. Shweta, please welcome Dr. YB sir. Now I request all the dignitaries on the dais to please come for the lamp lighting, and I also request Dr. YB sir and Dr. Solanki madam to come for the lamp lighting. We also have one more speaker, Dr. Trimbak Datta, who is the medical advisor, Zydus Life Sciences Limited. So please come for the light lighting. And I would like Solanki madam to welcome Dr. Trimbak Datta. So please. I would now request the dignitaries to be seated on the dais. I would like to announce the names of these speakers who are also there in our CME today. Dr. Smriti Vajpayee, she is the Associate Professor in Internal Medicine. Dr. Shrikant Jamdade, Assistant Professor in Pediatrics. Dr. Ravindra Devkar, who is the Professor Additional of Forensic Medicine and Toxicology. Dr. R.J. Zhende, Professor and Head Veterinary Public Health, Mumbai Veterinary College. And we also would like to mention the support behind all also. This is Dr. Harish Pathak, the Professor and Head and Academic Dean of our institute. Okay, so now I request you all to enjoy this CME till the end. We have a scientific and academic feast today, plus the breakfast and the lunch which you will also be having. And now I request Dr. Rosna to carry the further proceedings. Thank you.
Thank you, ma'am. Now I request Dr. Vijay Kumar Singh, Head of the Department of Community Medicine, as well as the organizing chairperson for the CME, to give an overview of the CME before we begin with the scientific session.
Thank you, Dr. Rosna and Dr. Swati Deshpande, madam. Respected Dean, madam, Dr. Sangeeta Rawat. The name says Rawat means tall, and I am proud to tell you that just today in newspaper yesterday, we had a very, very credible news that under the madam's leadership, we could do, our hospital could do the heart transplant surgery successfully. You can imagine, and for this CME also madam is present, and that is after 56 years we could do the second heart transplant, and it is now one of the known hospital all over the world after this surgery. Dean madam is always supportive for all the programs. Dr. Harish Pathak sir can be Dean. He also all the time, whenever we tell him, his guidance is always valuable. We have medical superintendent Dr. Mondasai sir. He personally is present over here, though he is very busy head of the Department of Orthopedics. But I'm thankful to him that for this CME, he is personally witnessing. All speakers already been told. Dr. Shahakar madam, HOD Microbiology, Dr. Datta, Senior Medical Advisor, Zydus Life Science Limited, Dr. Smriti Tiwari, Dr. Shrikant Jamdade, Dr. Ravindra Devkar, and Deepika Sadavarte, and Dr. Amit. We have very good team who has made this CME possible. Dr. Rosna, Dr. Rutuja, Pratik, Dr. Rahul, Sweta, Supriya, Naimika, and all my colleagues here present and residents from our college as well as all over other colleges. Mostly we have now 10 colleges in Mumbai, and people are, because of the rains, they might be a little late, but we have, madam, over 120 registration for this CME. As we know, rabies is most dreaded and 100% fatal disease. The global scenario is 60,000 annual deaths. 54% of that is in Africa and 56% in Asia, where India contributes 3/4 of the deaths. It is a very, very serious issue. Especially post-pandemic, COVID-19 post-pandemic, we have seen all over the world and also in India, the rising trend of rabies. There are so many reasons for which I will be covering in my particular speech lecture. Madam, KEM Hospital also, we see a lot of dog bite cases. Last year, we saw 1,135 cases from January to December. But this year, we have 580 cases till today, like from January to June. So dog bite is a problem in urban area as well as in rural area. As we know that World Zoonosis Day falls on 6th July, we wanted to have this program to observe, but today we have selected and we have taken the topic rabies. Now, with the goal of World Rabies Day to create awareness, World Zoonosis Day, create awareness, World Rabies Day is on 28th of September every year. Maybe we'll have another CME. The main purpose is to create awareness and to create or to see how far we are equipped to handle the cases of rabies in our hospital. Because this will give you review, this will give us review of those which are those guidelines which are there by Government of India, whether how much we are following it and how much is needed to see that cases, dog bite cases are managed properly so that they don't develop rabies. With this introduction of this theme, this CMEs will revolve around those topics. With this address, I welcome our Dean Madam, our ML sir, other HOD speakers once again. Thank you very much.
Thank you, sir. I take this opportunity to welcome you all once again to this multidisciplinary hybrid CME on rabies, rethink, modern solutions to an age-old threat. Also, I welcome Dr. Smriti Tiwari ma'am, who is one of the speakers for today's CME to the program. I request Dr. Y.B. Chavan sir to welcome her officially to the function. Next, I would like to call upon our chief guest, Dr. Sangeeta Rawat, Dean, Seth GS KEM Hospital, to deliver the Dean's address for you.
Good morning and warm welcome. Dr. Desai, Dr. Vijay Kumar, Chaya, Amit, and all the faculties of the CME and all the students. I think one of the most active department is community medicine. And they have been regularly arranging this, CMEs on various community and related topics, and I see that they all are well attended and well organized. So really, congratulations to the whole team. I think the rabies is something which is a preventable thing, and often it happens that, like I was just asking Amit, and we had 18 to 20,000 deaths in India due to rabies per year, and that means every 2 hours we have a death from rabies. So it's important. We do have many dogs here, even in KEM campus. In spite of all the efforts, I couldn't do anything to them. And I think Dr. Singh already reported that last year we had around 1135 dog bite cases, and till today in this year we already have 580 dog bite cases. And also we have announced that by 2030 we should have a national program that rabies should be eliminated. But in spite of that, I think the dog bite keeps happening. And the important thing is to get this rabies vaccine and the immunoglobulin. I think Louis Pasteur was the one way back in 1885 who started this vaccine first. I still have a personal memory of this. I went to a friend's place in Nasik. He had a pet dog, and in spite of that, he bit me. And it was like a grade 3 or grade 4 bite because I had a blood and everything coming. the panic which I got, though she said, the owner said, is fully vaccinated, but you never know what can happen. I said, fully vaccinated, a pet dog, why has come to bite me? I didn't understand. But in Nasik, we couldn't get that anti-rabies or anything like that. So we rushed from there, and the only place where I could get this was at KEM. That time I was not even a dean. But I came here and I got the, immunoglobulin, I got the vaccine, everything. So I'm really happy that KEM is providing this service. Though it comes in newspaper that it's not available, but I'm sure I've checked that every time we have this available, because this is something which is preventable disease if you take the immunoglobulin and this in time. And I think it's important that we spread this awareness that how important it is to follow up immediately after the dog bite. And I think such CMEs will definitely help for this. And I thank all the speakers who are going to be part of it. And I'm sure at the end of this, the students are really going to benefit. So congratulations once again and best of luck.
Thank you, ma'am. Now I request Dr. Vijay Kumar Singh, Professor and Head Department of Community Medicine, to felicitate Dean ma'am with a token of appreciation. Thank you, sir. Thank you, ma'am. Next, I would like to call upon Dr. Mohan Desai, Medical Superintendent, Seth GS Medical College, to speak a few words.
Respected Dean Madam, respected HOD Dr. Vijay Kumar Singh, Dr. Chaya Kumar, Dr. Rudra Solanki, all others, all my friends. The subject becomes dear and near to you when you, as Madam said, when you go through the experience. So I had small experience to share with my 2-year daughter. She is very fond of pets. She was playing in a garden, and then she met with this dog bit her, and again it was deep enough to have blood, and I was really frantic that time, and I had totally forgotten my all that old knowledge of I had to really refer to this, starting from the classification of the wounds and what. So I had spoke with many of my pediatric friends, and they said, no way, you have to take a immunoglobulin and anti-rabies, and immunoglobulin has some side effects, and you have to hospitalize that, or at least overnight, or maybe for 24 hours. So it was, and then I realized that this is not available. I was ready to go to any nearby corporate or any private hospital, but this immunoglobulin is not available. Any of the private, it is available only in the government setup. So I couldn't arrange that time, and it was KEM was too far. The nearest this thing was Cooper, but it was available there. But then somebody they find some way out, and they just gave a Rabies. Luckily, I got away with it. There was nothing, no reaction. There was no way that I could track that stray dog for 10 days and find out whether that dog dies or something. So, I mean, these are the experiences that make you perhaps richer. And I don't know why. Is that true that immunoglobulin is not available in any of the private? They are not supposed to give, or something. It's not available in any of the private. Means you are ready to pay, but is that true? Yeah. So I mean, something said we can boast upon or brag upon that we give that immunoglobulin, and then sometimes we are in the newspaper for the wrong reasons that it is not available. It is not available in the corporate hospital. Even you have to shell out money. So I think, yeah, so I mean, it is you realize how important is the topic which you are not realizing in your third MBBS days. You gradually realize, may it be statistics or may it be these diseases. Sometimes we are contacted for all these yellow vaccines. So many. I mean, it's an important department. I really admire and appreciate the efforts you are taking. And thanks for holding this important conference.
Thank you, sir. I request Dr. Vijay Kumar Singh to felicitate Dr. Mohan Desai, sir, with a token of gratitude. Thank you, sir. I also take this opportunity to welcome Dr. Ravindra Duka, sir, Professor, Department of Forensic Medicine. I request Dr. Vaibhi Chavan, sir, to kindly welcome, sir.
सर ने व्हाट्सएप एक मैसेज डाला, देखा आपने?
Thank you, sir. Now we'll be beginning with the scientific sessions. I request all the dignitaries to kindly take the seat in the audience. पेन ड्राइव डाला है ना, उसमें है सीडी. Hospital. Dr. Vijay Kumar Singh did his MBBS, DPH and MD Community Medicine from TNMC and Nair Hospital. He is also Associate Fellow of Industrial Health, Central Railway Institute, Government of India, Mumbai, and a FAMER Fellow. He has 35 years of teaching experiences and has worked in Nair Hospital, Sion Hospital, and KEM Hospital. He is a member, Medical Education Unit. He is a member, Academic Committee. He is a member, Scientific Committee of Multidisciplinary Research Unit, and also a PhD Guide Fellowship Course Coordinator. He is also Maharashtra Medical Council and MUHS approved resource faculty. He has around 22 publications, 2 national and 20 international, and his field of interest include medical education, biomedical research, epidemiology, occupational health, and MCH. Over to you, sir.
Thank you, Rosna, for a nice introduction. Rabies is my near to heart topic. If I go on giving you my experience, which I had last maybe 40 years or so, it will be very difficult for me to cover everything here. I wanted to share many of the cases which I have seen of rabies during my house post in pediatrics in Nair Hospital. But it is very difficult to compile everything in 20 minutes. So I have made myself disciplined so that I should not deviate myself, stick to the topic. few cases which I have seen in TNMC in pediatrics. The death is horrible. Just for a, just tell me how many of you have seen at least a single case. Seniors, definitely, because in our time we used to, those people also have seen. From where you have seen? James Aurangabad. You remember that case? So if you see those cases, then you realize what pathetic condition is there with the patient. Patient has to die alone. He has to be in one single room, left alone, and terrible death, which even relatives are not aware that time, what is happening with the patient. Okay, so this is a dreaded disease, 100% fatal disease. So I will take a small session on that. Okay, so that we just have epidemiology and some kind of history of rabies. Disease has terrified mankind since antiquity. The photograph, if you see, is the same patient who was alive just 2 days back and death in hospital with different phases of clinical phases. Rabies is a fatal disease, but vaccine preventable disease. This is very important. Causes fatal encephalomyelitis in man and warm blood animal. However, if ML bites are taken care of properly, treated properly, the disease and the death are preventable. When I say take management, it means it requires the proper wash by the water and soap, cleaning with the disinfectants, then injecting immunoglobulins in the case of 3rd degree, and also vaccination pre or post, whatever you say. Okay, whatever is the case like. So that is if it is done properly, then it is 100% preventable. Historically, the word rabies is derived from Sanskrit Indian word Rabies, means the violence. It was Democritus who made first recorded description of rabies about 500 years BC. Later, Celsius on the 1st century, his observation was that saliva of the animal was dangerous to cause rabies, and in 1804 it was Zinc who, by his experiment, confirmed that the disease was transmitted through saliva of rabbit animal. These are all ancient pictures I have taken because this has got ancient background. However, the historical breakthrough came through Louis Pasteur on 6th of July 1885 in Paris, France. He successfully used the nerve tissue vaccine developed by him and saved the life of 9-year-old boy, Joseph Mester, who was severely bitten by a rabid dog. Though the objective of this session will be basic concepts. We will see, for the cause of disease, epidemiology, mode of transmission, clinical features, and also we'll see how to assess risk of exposure and manage a case of bite by rabbit animal. And thirdly, we will see what is the national and the international efforts which are made to prevent and control this disease. The burden, the rabies is 100% fatal disease, which is already been told. Vaccine preventable, zoonotic viral disease affecting central nervous system, causing encephalomyelitis, leading agonizing and painful death. Globally, 60,000 deaths annually, 44% in Africa, and 56% in Asia. In India, we have almost 20,000 rabies deaths annually, 2 per lakh. 1/3, it contributes to 1/3 of global and 3/4 of Asia death in rabies. So we have 17.4 million animal bites occur per year. The disease is endemic throughout the country. with exception of Andaman Nicobar, Lakshadweep Island, and human cases of rabies are reported from all over country. Majority of the cases are from, they are poor, they are from slums, rural area, and they are children. Epidemiology. The animal largely responsible for transmission of rabies are dog, cat, monkey, wild animals such as mongoose, jackal, fox, hyenas are also implicated. In rural area, rabies takes toll of cattle, pig, donkey, sheep, goat, and other animals. In rural area, rabies takes, these are the animals which are generally been, they are domestic in rural area and they die because of rabies. Agent factor, the rabies virus is RNA virus, Lassa virus infection. It is bullet shape, measuring 75, 180 nanometers in diameter. It can be seen only under electron microscope. Virus is heat sensitive, gets destroyed in 5 minutes at 60 degrees Celsius and on exposure to direct sunlight. It can be inactivated by lipid solvents like iodine, phenol, Dettol, Savlon, alcohol, and beta-propiolactone. Now, the virus gets entry into the human body through the cuts or wounds by scratch or bite of the animal. Transmission. The rabies virus gets excreted in saliva, milk, and urine of the animal suffering from rabies. Most common mode of transmission are lick on the wounds, scratches by a rabid animal, and bite from rabid animals. It must be noted that the saliva of rabid animal is infectious or infective 2 to 3 days before the sign of rabies appear in animal. Occasionally, rabies can be transmitted by aerosols infection, namely in inhalation, especially in laboratory workers who are handling animals in case infested with rabies-infected pets. Drinking raw milk is not uncommon. In the rural area, it is very common that people, take direct raw milk from the animal. Organ transplant, also one of the important mode of transmission. Pathogenesis. The incubation period, the time interval between bite of the exposure to rabies and onset of clinical sign in the person ordinarily ranges from 2 weeks to 6 months in majority of the cases. The incubation period may be very short if the bite is on the face or head. It may be long as 3 years when the bite is on the periphery, like lower extremities. The virus usually enters the body through bite wound and then initially multiplies in the wound and muscles. Later enters the nerve root. It travels along the nerve through exoplasm and at the rate of 10 meters per hour. So these 4 pictures we have shown is in the sequence. Like one is the wound, then the virus entering into the wound, and then goes to the neuron, to the axon, and then it travels through the nerves, through the spinal cord, and finally the brain. The virus undergoes multiplication in the brain and gets disseminated to all parts of the brain. So once it goes to the brain and it gets circulated through the nerves. Okay, from brain to various secretory organs like salivary glands, hearts, reproductive organ, and kidneys, and where it multiplies. Now, it is important to know that in rabies, the virus cannot be detected in blood till the end stage of disease. That is, there is no stage of viremia in rabies. Clinical symptoms are very, very terrible. Rabies victims suffer horrifying symptoms and eventually die. Most pathetical, they know that the disease has no cure, but still they have to undergo that suffering and they will die soon. So there are two types of rabies in human, furious and paralytic rabies. So it starts with the non-specific symptoms like tingling numbness, then little, breathlessness, drooling of saliva, tears and respiration increases when it increases, it progresses further. Blood pressure becomes low. Patient develops hydrophobia, photophobia, and aerophobia. So these symptoms which we see generally when we are sitting in OPD or in casualty, the pediatric ward or medicine. So it is like an emergency. They come middle of the night and they get history of dog bite. By the history of dog bite, because they are referred, so we know that it's going to be rabies mostly. Okay, but if you get the case of rabies, which is in the initial period, it is very difficult to recognize that rabies is going to occur in this particular case, because those are non-specific symptoms and sometimes it presents like hysteria also. Now, approach to treatment management is the three I told you: management of wound, then anti-rabies vaccine, and also the passive immunization of rabies immunoglobulins. So these categories, I think it will be covered in vaccination chapter, but still just to overview of that: touching of animals, feeding animals, and licks on the intestine. This is the category 1, which needs no treatment except the wash. Category 2, minor scratches, abrasions, superficial nibbling of skin not associated with bleeding. It also requires wound treatment, and the course of anti-rabies vaccines are advised. Category 3 needs all these three. Now, World Zoonosis Day, and what is the ultimate efforts which we take? It is under the Sustainable Development Goal, and international collaboration. 4 bodies, namely World Health Organization, Food and Agriculture Organization, World Organization of Animal Health, and Global Alliance of Rabies, endorse framing the global support system to eradicate human death from dog-mediated rabies under 0 by 30 framework. And it is covering under One Health, which is the interaction taking place between animal, man, and the environment. Whatever diseases are transmitted through this interaction, to those diseases, and any disease should be actually considered in One Health. And we have stepwise approach towards rabies elimination. It is given by Global Alliance for Rabies Control. And we are following in India the National Rabies Control Program. Under that, we should have guidelines for OPD. What OPD we have? We should have wash basin, we should have proper area of disinfection. Okay, so all these guidelines are there that you can follow. Okay, and it is very important that if we want to go for NABH, then these things they will see, and each and every college has to see that if it is in OPD, then whether facilities are provided as per the guidelines given by government. Thank you very much.
Thank you, sir, for the wonderful session. I request Dr. Mohan Desai, sir, to kindly felicitate Dr. Vijay Kumar Singh, the token of appreciation. Thank you, sir.
The next speaker for today's CME is Dr. Chaya A. Kumar. Madam currently serves as the professor and head at the Department of Microbiology at Seth GS Medical College and KEM Hospital. She completed her MBBS from Mysore Medical College and post-graduation in microbiology from TNMC and BYL Hospital, and also FCPS in the year 1996. Madam has over 25 publications in national and international journals and also written a chapter in the book of IADVL, Handbook for Dermatology Residents. She has been awarded 2 international awards, 1 national and 5 state-level awards for her exemplary publications of oral and poster presentations. Currently, Madam also serves as the Secretary of Academic Committee at KEM Hospital and also served as the Convener for Medical Education Department at LTMMC. We welcome you, ma'am, to present the topic, Virological Aspects and Laboratory Diagnosis of Rabies.
Thank you. At the outset, I would like to thank Dr. Vijay Kumar Singh and also Dr. Amit for inviting me. And a very good morning to all of you. Okay, lab diagnosis. Why do you think it's important? Patient may be having symptoms and signs. They are having clinical manifestations. But are you sure that it is rabies? Because a patient can come with encephalitis or paralytic attacks, but encephalitis can be because of anything, right? So you need laboratory diagnosis for confirmation or to rule out. Nahi hai, nahi hai. So you need to know what are the different investigations, different tests to diagnose rabies. Dr. Singh has already said, it's been there through ages. In fact, most of the infective infections have been there through ages, and this is also one of them. The Babylonians in 2500 BC, they had to pay a fine if their dog transmitted rabies to another person. This is a historical aspect. I thought it would be interesting to share it with you. And initially, it was diagnosed via the clinical signs and symptoms which the doctor has observed. Then later on came the animal inoculation to isolate the rabies, etc., etc. It used to be the animals which were inoculated were initially rabbits and dogs, and later on mouse, and then they could isolate these organisms. But of course, they had to kill those organisms to detect those the rabies virus. Okay, I'm sure many of you will be interested in the history. I'll just briefly, just to acquaint you with what has happened throughout the ages. See if you see. Okay. 19th century, 20th century, and 21st century. So initially, the diagnosis was via the clinical manifestations. And then virus isolation, as I said, as I already enumerated. Then histopathology. Histopathology, what comes to your mind? Presence of inclusion bodies in Purkinje fibers. That's what you've read in UG, right? And then comes these tests, which are the gold standards. Direct fluorescent antibody tests. Then we have the molecular test, the real-time reverse transcriptase PCR. And then we have the direct rapid immunohistochemistry test. So this is the historical aspect of the diagnosis where rabies is concerned. Now, but how I am going to go through this lab diagnosis is what is the most important diagnostic test which you should be aware of and which are the gold standards. So first I'm going to cover that. So this is what is done now. This is a gold standard. Before this, I want to also I'm going to talk about the test, of course. But before that, you would also be wanting to know as to which samples would you like to take. Dr. Singh has already enumerated. Where are these organisms there? They are there in the nerves, in the neuronal cells. So you have to take a specimen which contains nerves. That is why in animals, you take the brain tissue, you take a cross section of the brain, and even in the brain, there are certain important parts like the hippocampus or the cerebellum, or less frequently, you can also find them in the brain stem. So you take biopsies from these tissues of the brain and then look out for them by doing various tests. You can also look at other innervated tissues like the back of the neck, at the hairline. You can take a biopsy from there, about 5 to 6 millimeters of biopsy, which contains around a minimum of 10 hair follicles, and which the depth of the biopsy should be where the cutaneous nerves are found. If you do not take a proper specimen, you do not get a positive test. You will get a false negative. So we don't want that. That is the reason why I'm focusing on the specimen which you need to collect. That's one. And please remember, just don't take one specimen. A minimum, you have to take, you can take the skin biopsy, you can take saliva. I think Dr. Singh has already said it disseminates from the brain onto the saliva. So you can take saliva as one of the good specimens. But of course, please remember, it is intermittently shed in saliva. It's not there all the time. So that is the reason why if you can take a minimum of 4 specimens in 24 hours by using a sterile pipette and then perform the test. So we finished with skin biopsy, saliva, and then we can take serum or we can take CSF. But serum and CSF is used for antibody detection. Whereas the skin biopsy and the saliva, you can use detect the antigens. So serum and CSF is for antibody detection. And antibody detection may not be diagnostic because in serum, the antibodies are developed later, are seen later. And the antibodies in serum are also seen when the person is vaccinated. But in CSF, vaccination may not, because of vaccination, you may not see the antibodies in CSF. So detecting antibodies in CSF means that the person has infection, is suffering from the infection. So please remember, serum and CSF also you can use to detect the antibodies. Last but not the least, brain tissue, I've already said. In animals, if you're suspecting an animal to have rabies, you have to euthanize it and take the brain tissue. In animals, would you want to take the brain tissue? Not as a first, because that is, it's traumatic. You wouldn't want to invade, it's an invasive procedure. So you prefer to use the other specimen. Okay, now let's go on and talk about the actual tests. DFA, the first test, this is a gold standard. Direct immunofluorescent test is a gold standard. Here you're detecting the antigens from the specimen. May it be saliva or it could be the skin biopsy from the nape of the neck. And of course, you can also use this test to detect the virus, the antigens of the virus from the brain. So, of course, it's not, this test is there only in certain reference centers or in major colleges or so, not there everywhere, not there commonly available as the other tests are available. Dengue, lepto, kahin pe bhi mil jati hai, but ye to milta nahi hai, it is there only in certain medical centers. So that is the reason why this another test, which is known as direct rapid immunohistochemistry test, can be used. This may be made available in the periphery, and this also detects the antigen. But the diagnosis can be available in less than 1 hour. What is this doing? This is using a fluorescent or a chromogenic component which is attached to immunoglobulin to detect the antigen, which is a nucleoprotein of the rabies organism. It's not very easily available. So next is the PCR. This is again the gold standard. Gold standard by WHO. World Organization for Animal Health, and also the CDC of which deals with which has the reference center for rabies. So this is declared as the gold standard for the diagnosis of rabies. And here you have conventional RT-PCR, reverse transcriptase PCR, you have amino-acid PCR, you have green real-time RT-PCR, but what are you interested in? You're interested in this LN34 tackling real-time reverse transcriptase PCR. This is the gold standard. And this has a real good advantage. You can use saliva, you can test on the skin biopsy specimen, you can test on, of course, brain tissue to hai, but what about even in formalin fixed tissues, you can use RT-PCR. Even in decomposed tissue, you can use this real-time reverse transcriptase PCR. So this is a distinct advantage. So you can use this real-time reverse transcriptase PCR, and it can be used as a gold standard. So, and here now, what about again periphery? Let's go back to the periphery. I mean, you just heard Dr. Desai and Madam saying, pata nahi kahan hai. We can, for testing to confirm, we don't know where the tests are there. And if it's there, it will be there in some reference center or in some big medical college. So don't you think we need some point of care tests? We do need point of care tests, right? But what are the point of care tests available in the market? Either they are good or they're very, very bad. Then they have to be more rigorously validated as of now. There is no standard point of care test which has been recognized by the WHO. But they are available and they may be used in the periphery. Okay. Okay, next is isolation of the organism. Now, when do you isolate? It used to be isolated, as I said, historically it used to be isolated by intracerebral inoculation of the mice. But now do we still go ahead and do it? Yes, we may do it because it confirms the diagnosis which you have done by direct fluorescent assays, PCRs and all that, especially if the results are not, you're not very sure of it. So then we might go in for this. Instead of using in vivo mouse inoculation test, you can use cell lines also. Cell lines like baby hamster kidney test or neuroblastoma cell lines. You can use those to grow the organism and detect the organisms by direct fluorescent assays. But only in doubtful cases we can do this in isolations. Serology. How important is serology? I've already mentioned briefly. This is for antibody detection. Serum antibodies develop, but a little late. And it could also be because of vaccination or immunoprophylaxis which you've given to the patient. But CSF antibodies do develop. And then if antibodies are seen in CSF, if it is detected in CSF, be assured that the patient is having rabies. And what are the tests available for antibody detection? You have this rapid fluorescent focus inhibition tests and fluorescent antibody virus neutralization test. You have indirect fluorescent tests also. And in fact, this is when do you use antibody detection apart? What are the conditions where you use? These are the conditions. When you give vaccination. And when you give vaccination, whether the vaccines you're given, if the schedule is not proper, then you're doubtful whether you're going to get, whether those vaccine is going to be protected. If the efficacy of the vaccine is doubtful, then again you do the testing for antibody. If the person is immunosuppressed, test for the antibodies. Yes, or in people who are exposed to, like veterinarians or those trappers or who go to these caves where bats are there. In them, if you need to do antibody detection, do the antibody detection for them. These are the conditions where you do antibody detection, not for routine diagnosis. Please remember, it is not for routine diagnosis. Okay, histopathology used to be done quite a long time back also. As I said, what comes to your mind when you say histopathology? Purkinje fibers. So in Purkinje fibers, you get these Negri bodies. Which are the stains? Hematoxylin and eosin stain. Then later on came the Sellers stain, which had a better sensitivity specificity, right? So a sensitivity specificity of 50 to 80% because of Sellers. But remember, about 20% of the cases can be missed by histopathology. So it's not foolproof. Then we have electron microscopy, but that's all research. You're not going to use electron microscopy. Firstly, electron microscopy is not going to be there everywhere. It's going to be in some research centers, and it is not going to be used as a routine diagnostic test. So you can see these Negri bodies. These are intracytoplasmic inclusion bodies, which are present if the patient has rabies. These are the electron microscopy. Dr. Singh has already described the morphology. It's a bullet-shaped virus measuring around 180 into 75 microns. This is histopathology, which is non-specific. This is perivascular cuffing, which is generally seen in encephalitis. But it is not necessarily that the encephalitis is due to rabies. And then you can see these Babes nodules, which is a collection of glial cells. These are histopathological features, which will be seen in rabies. But the prognostic pathognomonic feature in histopathology is what is seen, the Negri bodies in the neuronal cells. Okay, now we have done the testing, right? Now, do you want to know what strain you have isolated from the patient, and how would it be useful? Remember, rabies virus, there is one serotype of the rabies virus, but there are various antigenic variants which are specific to certain animals and seen in certain geographical locations. So detecting, knowing which strains or which species of the rabies is present in which geographical condition and in which animals they are present is very important, so that you can control your outbreaks. You can keep a hand over whatever is going on, so that you can recognize rabies. Okay, you can catch it the moment there are some cases and control it. You don't want a re-emergence of rabies, do you? Okay, so for that we need to do antigenic typing of whatever isolate you have had from the patient, or you can do molecular typing. You can use monoclonal antibody to do this antigenic typing. I'm not going to go into the detail of these typing. I just wanted you to be aware. So antigenic typing and molecular typing can be done by WGS or NGS. WGS, whole genome sequencing. NGS, next generation sequencing. So this will give you a complete history of that organism, about that particular virus. What are the future advances? We've talked about what diagnostic tests you're going to do presently. But what do you envisage in future? You can't just be stagnant. Because whatever tests are there, they are good, they're available, but they may not be perfect. You have to look out for more and more. So we can use other molecular tests like loop-mediated isothermal amplification, recombinase polymerase amplification. And then in fact, in India, there has been a battery-operated chip-based real-time PCR platform has been manufactured in India, which gives 92.3% specificity and 100% sensitivity. This is compared to direct fluorescent assays. And then you have this exome miRNA. These are molecular markers. These molecular markers are present in many of the infectious agents, in biofluids like your blood, urine, saliva, CSF, and these are stable. And you can get the concentrate. You can get you can quantify it. So detecting this also would help in giving you a clue that it could be rabies. What has it? And then you have RPA CRISPR. This is again a molecular test with genetic coding or genetic targeted gene editing. And this principle can be used to have a point of care test. So we can explore all these possibilities as future advances. Again, we can develop, we have NAT, nucleic acid amplification test for TB, for hepatitis B. We can use it even for, we can get it even for rabies detection. Okay, so please remember, to summarize, antemortem, multiple tests are necessary, not one test, especially if it is negative. Don't be negative hai to bas wo negative nahi. You have to perform multiple tests to confirm. And for those tests, these are the specimen which you would use. No single test is sufficient. Please remember this. Postmortem, of course, your brain tissue. Negative antemortem test strongly indicates no rabies, provided you do those multiple tests, not one test. But confirmatory postmortem testing is recommended if no alternative diagnosis is found. So this you need to remember. So this is a summary. So all said and done, you can do antigen detection. You can do genetic, the nucleic acid detection by PCR. You can do antibody detection. Antibody is not diagnostic. Or you can do isolation to confirm in doubtful cases. And postmortem to aapko karna hi hai in animals after euthanizing. Not preferred brain tissue is not, you don't have to use it in antibiotic cases in humans. Okay. Yes, I forgot about immunohistochemistry. Immunohistochemistry, initially I had said direct rapid immunohistochemistry. That can be again done in field area. Immunohistochemistry now can be used in pathology for those specimens, histological specimens. Here, what are you doing? Here you're using a streptococcus biotin immunoperoxidase reagent attached to the immunoglobulin and detecting the antigens. But here, this test can be done in formalin-fixed tissue, not on fresh tissues. So, what are the main takeaways of this talk? Diagnosis has advanced from crude, unscientific methods to highly sensitive and specific assays. Advancing diagnostic technologies has allowed for production of early vaccines, as you're all aware, for timely treatment of animal bite victims, to help investigators understand viral transmission patterns in wildlife, and to aid public health investigations by identifying sources of outbreak. What about those advances? The future of rabies diagnostics, I've talked about the advances there, promises to expand highly sensitive and specific diagnostics to developing countries, offer early disease diagnosis using less invasive antemortem testing, and also aid in global rabies surveillance. Thank you.
Thank you, Dr. Chaya ma'am, for such an elaborate and illustrative explanation on the virological aspects and laboratory diagnosis for rabies. I now call upon our HOD sir, Dr. Vijay Kumar Singh, to felicitate Dr. Chaya ma'am. Thank you, ma'am. Thank you, sir. Before we move on to the next session, an earnest note from the organizers to the dear speakers. Kindly stay back to your time schedules for smooth conduction of the CME. I call upon the next speaker for today's CME, Dr. Triambak Datta. Sir has completed his MBBS and post-graduation in clinical pharmacology from MGM Medical College and currently serves as the senior medical advisor at Zydus Life Sciences based in Ahmedabad. Sir has a clinical and research experience of over 12 years and has over 21 publications across various leading journals in multiple therapy areas with special interest in vaccines and biologics. I welcome you, sir, to present on cocktail monoclonals in management of category 3 animal bites with adherence to WHO guidelines.
A warm good morning to all of you. I welcome all of you on this cold and clammy weather day, and it's really appreciated that you made it to this CME. I am Dr. Trambak, medical advisor for Zydus Vaccines, and I shall be talking upon the important and a very imminent topic of monoclonal antibodies in rabies post-exposure prophylaxis. So, as already been highlighted by the dignitaries and the speakers before me about this topic, I will just reiterate on the same, specifically on a particular problem in this country. So, in India, we understand that rabies is endemic, and there are deaths happening every hour. So in a 1 hour of this session, at least 2 deaths would have happened, which might have been accounted for or not accounted for, because you understand that in this country, a lot of rabies deaths are also not accounted for because it's a neglected tropical disease. And that's the reason WHO has designated it so. And based on that, the government of India's working guidelines are pretty stringent and strong. The government is basically working on NAPRE, which is the National Action Plan for Dog-Mediated Rabies Elimination from this country by 2030. And based on similar lines, Zydus has actually collaborated with WHO, that is the World Health Organization, to create TwinRab, which is world's first novel cocktail of monoclonal antibodies in rabies PEP. So, given the context of rabies, all these animals on the screen, which might be visible to you, but I'll just read them out. Like we have foxes, bats, monkeys, dogs, cats, mongoose, and camels. If you see that most of the animals which are wild are considered to cause rabies, but in the urban areas, mostly dogs and cats, as well as monkey bites, are, we warrant rabies PEP for these bites. However, in India, there is a myth that, rodents might cause rabies, but usually rodents are not considered to spread the disease. But are we really aware of the categorization of rabies bites first? So we'll briefly talk about that. There are 3 images on the screen. The image number 2 might not be very visible to all of you, but image 1 and 3, both of them have, blood coming out. So any site of blood is category 3 bites. So you can see that these are all scratches with blood. This one is not visible to all of you. So I'll just leave this image number 2, but image 3 also is a bite with blood. So all of these are category 3 bites. And when you talk about category 3 bites, they require the complete rabies post-exposure prophylaxis. But however, if you see the transmission risk, anatomically, if it is the upper extremities which are affected by the bite, then there is higher transmission risk of the rabies virus, because there is retrograde transmission of the rabies virus to the spinal cord and finally to the brain. So mostly in the pediatric patients, because what we have seen across, talking with the rabies care specialists across the country, most of the pediatric patients are at higher risk because their height is less and mostly they get bitten in the upper extremities. If you can see over here in a single shot, you can see all the 3 categories of bites. Of course, the category 2 and category 3 will require the anti-rabies vaccine. The category 3 will require the immunoglobulins as well as the monoclonal antibodies as a part of the passive immunization, along with the active immunization of anti-rabies vaccine. So what is the right rabies PEP? It is a combination of all these 3, which is for the category 3, ideal category 3 bite with blood. First is the wound wash with soap and water. It's a very classical example, and it's very, very important for any anti-rabies clinic, as well as an anti-rabies particular structure. If it is there in any hospital, it should have a wound wash facility with soap and running water specifically, because the virus is susceptible to soap because of a difference of pH, and running water is very, very important, needs to be washed. The wound area needs to be washed properly. This is the very first basic step in treating the category 3 bite. Then comes the two important pillars. One is the anti-rabies vaccine and another is the RMAP. Though this presentation is mostly concentrated on the passive immunization, but still I'll take a moment and talk about the anti-rabies vaccine as well. If you see, the WHO recommendations are there for intradermal usage. Why it recommends the intradermal usage? Because if you compare the intradermal versus the IM usage, then much lesser amount of vaccine is required in the intradermal usage. And that is very much recommended by the WHO in order to save vaccine for the developing countries. And the number of dosages are also less with intradermal. However, if you give the intramuscular, then there is more number of dosage and more utilization of the vaccine. Coming to the rabies immunoglobulin or the RMAP, now the WHO recommendation are solely for the infiltration in and around the wound only. So earlier on, the WHO used to recommend intramuscular usage as well for the immunoglobulins. However, as per the latest position paper on the rabies vaccines, we have seen that the recommendation changing to only intralesion transfer. So basically, if you're giving the ERIG or HRIG or the monoclonal antibodies, then what happens is you need to only infiltrate in and around the wound. And that should be enough. So basically, this is the complete rabies post-exposure prophylaxis for category 3 wound. So we will see the current picture and we'll talk more about the current modalities which are present. If you see the WHO modalities which are present right now first is the human rabies immunoglobulin, which is approved at the dosage of 20 IU per kg. We have the equine rabies immunoglobulin, which is prepared in horses, and it is approved at the dosage of 40 IU per kg. And we have the single monoclonal antibody as well as the cocktail of two monoclonal antibodies. The single mAb is approved at 3.33 IU per kg, and the cocktail of two monoclonal antibodies is approved at a dosage of 40 IU per kg. Given the dosage scheme, which we can see over here, you can easily make out that the higher doses are there with the cocktail of two monoclonal antibodies as well as the equine rate for that matter. Both of them are approved at 40 IU per kg. So talking about why passive immunization is important, because you understand that India is a very big country, and I have been traveling in this country and speaking with rabies care specialists and specifically community medicine experts across the country. When we go towards the areas where there are more of jungles and more of forests, or maybe the hilly areas of this country which are less have less coverage of healthcare facilities, it's very difficult to provide passive immunization to patients. Doctors do provide the anti-rabies vaccine, but most of the times we have seen that passive immunization might not be available for the patient. There might be access issues. So why passive immunization is important? You can see this graph, and to be very precise and brief, if you see this particular line is actually the antibody which is rising because of the anti-rabies vaccine. 0.5 IU per ml is the cutoff titer, which is recommended by the WHO, which should be there in the serum for protecting against rabies. So if you see the passive immunization, this line is the passive immunization. So what is passive immunization? It is the ready-made antibodies which you are providing to the patient. So that's why WHO recommends it directly at the wound site. So if you give the passive immunization, then you are directly giving the 0.5 IU per ml. However, the anti-rabies vaccine will take at least 7 to 9 days for it to reach to that level. So these are the reasons the passive immunization is important. So basically, that is the reason why we actually talk about and giving the ready-made antibodies. Further, there are issues with the existing immunoglobulins, unavailability, unaffordability, specifically when it comes to human rabies immunoglobulin, risk of burn-borne infections with HRIG, high volume of infiltration which is required. We'll try to see that quickly on a slide because there is limited time. Most of the HRIG is being imported from countries like, for example, HRIG is being imported from Israel, currently war affected, as all of us know, and there are shortages. Similarly, ERIG requires the skin sensitivity test. So these are all the issues, and also for the single mAb, there is the issue of viral escape. So all of this can be mitigated by use of cocktail of monoclonal antibodies. So for these issues, we have launched the TwinRab, which is in collaboration with WHO. It is the combination of two monoclonal antibodies, docaravimab and miromavimab, sourced from United States and Canada. So this is the composition of TwinRab on the screen. And the mechanism of action is, if you take this to be the rabies virus, because the rabies virus is a bullet-shaped virus, so you can consider this cylindrical portion as the part of the G protein of the rabies virus. So mirovimab binds to site 2 and docaravimab would bind to site 1 or 3 on the G protein. So at any point of time, the neutralization of the virus is guaranteed. So these are the documents of WHO, wherein it directed to create combination of 2 monoclonal antibodies, that is TwinRab. And when we talk about the preclinical studies, you can see these are the preclinical studies versus human rabies immunoglobulin, wherein you can see non-inferiority of the same. So here also you can see TwinRab provided 100% survival rates compared to HRIC. These are preclinical studies. Again, vaccine plus HRIC versus vaccine plus TwinRab. It provided more survival rates, 88.9% versus 77%. So these are the Indian isolate street studies for the TwinRab versus ERIG and HRIC. So finally, we come down to the clinical trials of TwinRab. This is phase 1. In phase 1, we tested whether TwinRab at what doses it will be appropriate. So what we saw is at 40 IU per kg, it had the maximum area under curve from day 0 to day 7. So wherein, the passive immunization is indicated. So we've finalized the dosage as 40 IU per kg. And you can see over here, this is the details of the clinical trial of phase 1. Wherein we took the 40 IU per kg as the dose. And this comes to the phase 2, wherein we took the 40 IU per kg and saw that versus placebo, there was significant increase in the titer levels from day 0 to day 7. So basically, this is the purple one is the placebo plus anti-rabies vaccine arm, and the orange one is the TwinRab plus the anti-rabies vaccine arm. So here you can see clearly that TwinRab along with the anti-rabies vaccine created much more area under curve in day 0 to day 7 area where passive immunization is required to be given. Finally, the phase 3 study, I would like to emphasize that our phase 3 study of TwinRab is versus HRIC, which is IMOGAM. So versus this human rabies immunoglobulin, if you see 2 arms were there. In the first arm, TwinRab versus anti-rabies vaccine was there. And in the second arm, there was the human rabies immunoglobulin plus vaccine. So you can clearly see that the primary objective was that how many of the patients are getting the more titer levels than 0.5 IU per ml, which is the WHO recommended titer. So we did this multicentric study, and you can clearly see versus HRIC, TwinRab fared quite well and non-inferior because the p-values are non-significant. So this comparison is non-inferior to each other, and we see that the serum IU levels of the RFID titer to be more than 0.5 IU per ml. So at day 28 and day 42 also, you can see non-inferiority of TwinRab in terms of reaching the IU levels. And it is the most important part is that TwinRab is not interacting with the vaccine, because when you give monoclonal antibodies or immunoglobulins, there is always a chance of interaction with the vaccines, but it is not interacting with the vaccine and not reducing the antibody level of the vaccine. These are the summary of adverse events. Mostly the adverse events were minor, mild, and they resolved on their own. There were no deaths reported and no rabies breakthrough infections reported after the clinical trial. These are the SKUs which are approved in India. We have the 1 ml and the 2.5 ml in India, and also the 5 ml and 10 ml to be approved for the institution. So this slide is very important because this sums up the entire current scenario of rabies PEP. If you see TwinRab is there, we have the single monoclonal antibody, the ERIG is there, and the HRIG is also there. So I'm just hopeful that if it should be visible to you, for a 30 kg patient or for a 60 kg patient, you might find the dosing calculators also outside. So you can also help yourself with that. So we understand that TwinRab is approved at 40 IU per kg. So for a 30 kg pediatric patient, for example, 1200 international units will be required. And for the same, how much ml of dose will be required? So since the potency of TwinRab is 600 IU per ml, though we divide the IUs by the potency, so we get the dosage, which is 2 ml is the dose which would be required for this patient. So comparatively, the single mAb is approved at 99, is approved at 40 IU per ml potency. So basically the dosage will be required is 2.5 ml. For ERIG, it will be 4 ml, and for HRIG, it will be 4 ml again. Compared to a more weighing patient of 60 kgs, if you see 4 ml of Twinrab is enough. However, for the single mAb, it is 5 ml. For ERIG and HRIG, since the potencies are lesser, the 8 ml of both of them will be required. So what is the point is that the volume of administration for Twinrab is least because the potency is the highest. So the guidelines, when we see the guidelines, the Indian Academy of Pediatrics recommends Twinrab along with, of course, the WHO, because it is being prepared with close collaboration with the WHO. It is also there for, the recommendations are also there from APCRI as well as NCDC. We are expecting the guidelines very soon. So basically, these are the 7 reasons for prescribing Twinrab, which is, of course, if we summarize them, it is the world's first novel cocktail of monoclonal antibody, which neutralizes a wide variety of viruses with no risk of zoonotic infections. So we would like to update all of you on the post-marketing surveillance of Twinrab, which we have done just now, finished just now across the country, across 5 centers. From Pune, the BJMC and Sassoon Hospital was one of our centers, which is a center of excellence of rabies in Pune. We have IDBG from the Eastern India, KIMS from Bengaluru, MAMC from Delhi, and GMC Patiala. So this trial was registered at CTRI and completed with 1519 patients across the country, which summarizes the safety of Twinrab. So these are the publications. You can go into PubMed and search them. This is the first publication for the PMS study, which is from the IDNBG Hospital, Calcutta, which sees approximately 160 to 200 category 3 bite patients per day. So here we have seen that approximately 9.9% of adverse events, those were mild and moderate, mostly mild adverse events out of 401 patients. No breakthrough of infection with rabies. Twinrab was administered at a maximum dose of 3,800 international units. This study also talked about the safety of Twinrab from 1 year of patient, that is the pediatric age was 1 year till 90 years of patient, which was the very important point of this study. Further, the BJMC study from the Sassoon Hospital, Pune, also talks about 1.3% of bites patients. And it also talks about the pediatric patient range from 2 years to 17 years and so on, with a maximum dosage of 4280 IU of Twinrab safely administered. We already going to get published with the MAMC study, which talks about the safety of Twinrab at a doses of 8.33 ml, which is a very high dose for that matter. Further, the KEM study at Bangalore also talks about the safety of Twinrab at a higher dose of 4520 international units, going to be soon published at Journal of Global Infectious Diseases. Here, the 97% of doctors and 97% of patients talked about excellent response to the prophylactic treatment. So Twinrab is very much there in the WHO guidelines, very much there in the WHO essential guideline booklet. And also, if you on the screen, you can see the WHO position paper talking about Twinrab from the WHO Geneva. So Twinrab versus the single monoclonal antibody, I will not talk much, but then definitely there is viral escape phenomenon with the single mAb compared to the combination of these 2 mAbs, which is there in Twinrab. Also, we have already talked about higher potency of Twinrab compared to all the existing modalities of prophylaxis. So to summarize the entire CME, specifically on this particular important and critical topic of rabies PEP, Twinrab is the world's first novel cocktail of monoclonal antibodies. It is safe in both pediatric and geriatric population. It is 3.5 times cheaper than HRIC because cost becomes an issue whenever we create the healthcare policies, and even if the patient has to buy it on their own. And it is WHO, APCRI, and IAPAC-VIP approved, and we have 2 publications already come up in the PubMed index journals for the TwinRab PMS. 3 more are soon to follow. We would also, before concluding this CME, would like to reiterate on the importance of the awareness which is being created by the rabies experts. You can see on the screen. So as already being discussed, that we had World Zoonosis Day on 6th of July, and we also had this particular session wherein these rabies experts talked about eliminating rabies by 2030 and reiterated on the NAPRAISE plan of specifically improving the situation by adopting better rabies PEP. So thank you so much, everyone, and thank you for giving this privilege to talk on this particular platform. Thank you so much.
Thank you so much, Dr. Datta, sir, for introducing the novel monoclonal antibody for the management of rabies. I now request Dr. Vijay Kumar Singh, sir, to felicitate Dr. Datta. Moving on, we have the next speaker for today, Dr. Smriti Tiwari. Madam is an associate professor in the Department of General Medicine at Seth GS Medical College and KEM Hospital. She completed her post-graduation in general medicine and various fellowships and is also a FAMA fellow. Madam has expertise in the areas of infectious disease, HIV, and is also a keen academician with interest in medical education. She has over 40 national and international publications. I welcome you, ma'am, to present the recent advances in medical management of dog bite.
I thank at the outset the Department of Community Medicine, Dr. Amit, for giving me this opportunity to speak with you all. I hope and try that with my short talk of 20 minutes, which might get reduced to 10 minutes, depending upon what all has been already covered to you in the previous talks. I hope I'm able to add something to your knowledge after you hear me out. So the topic says recent advances in the management of dog bite. Now, pretty much a lot of it has already been covered. So take this as a revision and probably a crisper version of what you have already heard. So let's start with some scenario base, where I give you first scenario of a 25-year-old or a 24-year-old male who comes to the physician with a history of scratch and a probable bite from a street dog while he was strolling in the night on the road. Around 6 or 7 hours have passed, and since this bite has come to you, and he comes to the physician. So let's see what happens and what would you think of as a physician if this scenario, a very common one, approaches you. So the physician's role is the chronology in which I have posted in the screen. You can say that chronology is very important. So the first would be wound management or assessment and categorization, followed by wound management. The second is the role of PP. So wound management, as much as I can emphasize on that, is very, very essential. Everyone in the community as a lay person should be made aware of this, that the vaccination is the second part of it. The wound management is the immediate action which can save a lot of lives just by appropriate wound management. So the assessment and management of the wound along with categorization of the wound is very essential. So as it was stated, we categorize wounds into 3 categories, category 1, 2, and 3. Now this also is important to remember that category 1 wound, which are very common in situations of panic. Patient comes to us, it was a home pet, just licked me, the cat licked. Now these licks, where there is no scratches involved, where there is no break in the continuity of the skin, come under category 1. And these, just on the part of physician, require allaying the panic and the anxiety of the individual. they will come to you with saying, please give us anti-rabies vaccine or please give me RIG. How do you know that that person, that's the role of the physician. How effectively you counsel the person that this is a category 1 wound and doesn't warrant anything of the next categories. Okay. Whereas in category 2, now these are wounds where are, for example, scratches, no bleeding. So blood, the moment blood comes into a wound, it automatically goes into category 3. Now I'm keeping things simple so that it stays in your mind. You know, it's very good that when I'm presenting here or we are here on a CME, you know, everything comes to you. But when after 4-5 months you are on ground, you know, majority of this gets wiped off. So then these crisper versions of scenario is what stays back in your mind. So just keep that in your thought process. That person has come to me, there's no bleed, it comes to a category 2 wound. The moment there is a blood there, it will be a category 3. Okay, so I need to be here. I'm sorry. She says, I'm also on online. So category 3, the moment there is a wound. Any wound, scratch above the neck becomes a category 3. So something on the face, even if there's no bleeding, remember this is what I'm saying. So anything which is on the neck, close to the eye, on the face, scratches become category 3 bite. And sad to state, but the fact is in pediatric age group, there are more chances of kids getting these scratches, you know, over the in the upper part of the body. And because keeping in mind the pathogenesis of rabies, the chances of the virus transmitting to the brain is faster from the upper area. It's always recommended that these bites or scratches, injuries on the upper portion of the body taken as category 3. So that becomes category 3. Category 3, other thing to remember, any sort of bite, scratch from a wild animal becomes a category 3. Dr. Datta did state that rodent exposure doesn't warrant. So in Mumbai, there are a lot of exposures to rodent which keep happening. More so you will see that in slums, people are staying, you know, we have had children being bitten by a big mouse and, you know, rats. So that doesn't warrant a anti-rabies vaccination or a PEP for rabies because it's not transmitted. But monkey bites, monkey scratches, coming up very much in Mumbai, you will see, because we have, you know, buildings coming up just next to, you know, all these forest areas. We are entering the forest, so obviously, you know, going into their area of stay. So monkey bites are very common in Mumbai. They warrant rabies, anti-rabies vaccination and PEP. So that's important to remember. So for us, practical purpose, cat, dog, and monkey. These 3 are very important. For all forest bite, for all wild animal bites, very important to have PEP prophylaxis for rabies. So that's the categorization. The next comes wound management. So look at the wound, thorough washing. Thorough means running water best. Okay, minimum for 15 minutes. Simple soap water wash is good enough. Okay, after the wound has been washed, apply a povidone iodine, which is a virucidal ointment, or any other ointment, could be a spirit as well. Okay. Suturing, if warranted, depends upon how deep the wound is, how much the laceration has happened, is also not contraindicated. So in previous guidelines, suturing was contraindicated, but in the recent guidelines, they say if it is warranted, a secondary suturing can be done, taking into consideration the active and passive immunization, which will come to the next. Application of this, then infiltrating RIG or rabies immunoglobulin in and around the site of wound. Wound should be washed even if person reports late, but the wound is still unhealed and can be washed. So this is very important. So when Sir Singh Sir was saying that in an area where you're going to provide anti-rabies vaccination, they are even you know, promoting that you should be having a wound cleaning area. So even if they have reported late, one doesn't know how thorough the wound was washed. And if you still feel it is still going to have efficacy in the form that even if there's a limited amount of virus which can be prevented from entering, can have serious impact on the pathogenesis of this disease and prevention. Tetanus vaccination should be given as per the requirement of the patient. So if they don't remember their tetanus vaccination, should you give them? If they know that, within last 5 years, I have taken a tetanus vaccination, you don't need to. Otherwise, a Tdap is indicated in adults. In pediatric population, depending upon their vaccination status, you need to vaccinate for tetanus. And also depending upon the wound, whether antibiotics are warranted or not. So if you feel it's an infected wound, a bad wound, very, too much of laceration, go ahead and give a antibiotic course as well. So this is as far as the wound management goes. Next comes passive immunization. So as we know, there are 3 things available: the equine rabies immunoglobulin, the human rabies immunoglobulin, and monoclonal antibodies, which we just talked about. So this is indicated for all category 3 wounds, all wounds or bites of wild animals, as I just said, and all patients who are immunodeficient. So if you have a person who's HIV positive, even if gets a category 1 or a category 2, might have to go and manage them as category 3 bites by giving passive immunization. Anybody who's on chemotherapy, anybody who's on steroids, prolonged steroids, leading to immune system being deficient, in those cases, they have to, you have to give the passive immunization. So you have to easily accessible, the time tested, the prolonged immunoglobulins which are available, the equine one and the human rabies immunoglobulin. The equine is heterogeneous in natures and has the chances of anaphylaxis, although it's not as much as it is supposed to be, propagated. So we have had patients, we have been giving ERIG for a very long period of time, and I have yet to see any major anaphylaxis, but there are reports, so we cannot completely ignore it. But one doesn't need to be scared about the fact that anaphylaxis is there, so let's not give ERIG. You can still go ahead and give it. The other thing is it requires a higher dose, about 40 international unit body weight. So to give you an example, one of the brands I've mentioned, Equirab there, which is very commonly available ERIG. For a 60 kg person, the approximate cost of this comes to around rupees 1200. Again, giving you this perspective, because when you are on ground actually prescribing them, you need to also think about cost factors. Because otherwise, we are in a country where it's not so easy. You just prescribe anything and the person is going to bring it. So keep these facts also in your mind, which will help you in actually prescribing what vaccination I'm doing. Whereas if you go ahead and think about the human rabies immunoglobulin, which is homogeneous in nature, no anaphylaxis reported, dose required is also less. But look at the cost. The cost for a 60 kg man comes to around rupees 12,000. Which is human rabies immunoglobulin. Here I have mentioned is QRIG. There are many more available also. Also to bring to this notice, when Dean Madam said that there is a lot of paper reportings or media reportings that it's not available. So pretty much they're talking about this, that it's not available. Now it's not available also because look at the cost. No, not an easy thing for even a probably an upper middle class person also. If you now, I have taken a 60 kg weight. No, weight does vary in individuals. So the cost also keeps changing. So 12,000 is not a very cheap option to think of. And that's why they say it's not available in the government setup. No, it's not like that. We have options, cheaper options we've been giving to the patients. Patients are benefiting, but media sensationalism, and that is why we get to hear those things. Immunoglobulin provides passive immunity till the antibodies are formed. So you do start active immunization, and within the first 7 days, this immunoglobulin will provide antibodies till the actual rabies vaccine starts to function. So the maximum amount of this passive immunoglobulin needs to be infiltrated in and around the wound without causing compartment syndrome. Now, this is important because if some wound is there on the face or at the tip of the ears or tip of the fingers, now these are the places where if you are injecting locally, there are chances that you might land up with the compartment syndrome. So one has to be careful about it. And let me tell you, NCDC has a beautiful document published in 2023 about how to manage dog bite, detailed version, how to give injections, intradermal, intramuscular. So whenever, if you get a time, it's a, I think so, 97-page document, which talks about all these aspects for a ground level worker, for an MO, how to actually manage a dog bite. And they're very beautifully given this. The other, which is known, which is there in WHO, so I need to mention that, are the monoclonals. Now, if you look at it, the cost does look very reasonable if you keep rabies, human rabies immunoglobulin in mind, but it is still expensive. It is around 4,000 rupees for a 60 kg man. The other brand which is available is the Twin Rab, which we talk about. The cost of that is around roughly 6,000 for a 60 kg man. Again, this is there in the market. Okay, so if indicated, if affordability is not an issue, I would recommend that you go ahead and give this, because it has shown equal efficacy. It is an approved medication. WHO is including it in its management strategies, so one can go ahead. The next part is the active immunization, and there are a number of vaccines which have been approved and they are available. Now these, how are they different? So they're actually different depending upon the substrate which is being used for growing the virus strain, and accordingly there are. So that's how you see the human diploid cell vaccine, the purified tick embryo vaccine, the virocell rabies vaccine, and a whole lot of these 8 brands which are available in the market. The common ones being Abhyarab, Rabipur. I'm sure Rabipur has been the oldest, which every one of us know it. So there are many more which are also there, Virorab, Vaxirab, anyone can be used. Now, to give you again, the cost of this is quite reasonable. So the dose, single dose, costs around 400 to 300 to 500 rupees. So it's not very expensive. Then the active immunization brands, and keeping in mind the various brands goes. So these are various brands which are there available in the market of active. The vaccine should be administered intradermally as per the WHO. Now, as Dr. Datta also stated, you can give both intramuscular as well as intradermal. Why intradermal? Keeping in mind that the amount which is required in intradermal is much less, but the efficacy is equal. And that's why they are now advocating the use of intradermal. Also, we have to keep in mind when the community part of it comes into picture, where we are dealing with big lot of chunk of human population who are at risk of rabies. Countries like India, countries like Pakistan, these are poor countries, and you have to handle a big lot of, he was mentioning about rural areas, about wild areas, interiors of countries where the reach is very less. So then the amount and the cost, how much, how fast, all that comes into picture. And that is why the WHO thought about this. They did studies and they found that intradermal reduces the cost, the amount which has to be given, but the efficacy is not compromised. So they are advocating intradermal. Again, it is not very difficult. All of us who have been trained in MBBS have been trained how to give insulin injections, have been trained how to give PPDs, very similar to that. Absolutely similar to it. So when you're giving, you have to see that there is a bleb which comes once the intradermal has to be given. If the bleb doesn't come, then it is not intradermal. It's gone beyond that. And so the efficacy will be a little less, but it is not that you have done something really and you need to repeat. It's not like that. The intradermal dosage is around 0.1. Okay, first let me tell you about the intramuscular dosage, where that is 1 dose of vaccine administered on day 0, 3, 7, 14, 28. So total 5 doses. Intradermal, 4 doses, only 1 gets reduced. So that 14 day gets removed, and it's 0, 3, 7, 28. So 4 doses, but 2 sites. So every day there are 2 sites which are chosen. Usually the sites which have been recommended are deltoid, anterolateral aspect of the thigh, subscapular. Okay, so these are the places where you give intradermal, same as an anterolateral aspect of thigh, and deltoid for intramuscular. Gluteal not to be used for intramuscular injections if you are giving intramuscular also. Now let me give you scenario 2. So this was a little bit keeping in mind scenario which one. This scenario is a 26-year-old boy reports to a physician that he has had a dog bite a day before. Dog is a neighbor's pet. He also reported that he was bitten by the same dog 6 months back and he had received PP for the same. What do you advise for this person? He's been bitten before, received post-exposure prophylaxis. It's a pet dog. Okay, so no passive immunization indicated here. For active immunization also, 2 booster doses are prescribed, either intradermal or intramuscular on day 0 and day 3. So if there is a re-exposure happening within 3 months of PEP, then nothing would be required except the wound management. But because it is beyond 3 months, then a booster in the form of 2 doses of anti-rabies vaccine are indicated, although no passive immunization. Fine? Okay, let's come to scenario 3. This is a 23-year-old veterinarian student approaches to the physician stating that she has been advised by her faculty to get immunized with an anti-rabies vaccine. So here what we are dealing with is a pre-exposure prophylaxis, not a post. The vet are more at risk for getting these dog bites, and so they have to take care that they are immunized. So pre-exposure prophylaxis, the groups of persons who are at high risk to these live rabies like lab staff, vets, animal handlers, wild dog lovers. Mumbai is full of dog lovers these days. And dog lovers to such an extent that street dog lovers. So they are feeding street dogs in spite of that being illegal. And I'm sure every society in Mumbai, there are certain, quarrels keep happening. These are dog lovers. So they are at risk. They need to be vaccinated. Children living in or visiting. Trust me, children are the most prone. And that's why you have a section on pediatrics after me. Because first of all, the bites are more over upper portions of the body, which is a higher risk category bite. Second, these kids don't have that sense of fear to the animals. So they approach these animals also. They will be the ones who will be touching, licking. And as I said, so we need to be careful with the children. Travelers to rabies affected areas according to the risk level. So again, 1 intramuscular dose is given on each day of 0, 7, 21, 28. Same vaccine. Here, as you can see, there are 4. Site of injection, as I mentioned, intradermal. Then what you do is 0, 7, 21, 28. The dose here becomes reduced. So 1 intradermal, 0.1 ml. A routine booster is not recommended once complete immunization is done. But if the risk is high of the person or he is not aware of his vaccination status, then ideally you should check the antibody levels. And if the antibody levels are below 0.5, then the booster should be given. So in summary, these are the various schedules of intradermal and intramuscular. As I said, intradermal, if you're giving 4, otherwise 5. For intradermal, 2 sites, 0.1 ml needs to be given. And to end by saying that for any animal bite, the first things I would say is avoid panic. Wound cleaning is very crucial. And if there is any confusion, please vaccinate. Now, if you're not sure whether it was category 1, 2, 3, better to vaccinate or on the positive side rather than not. Thank you very much.
Thank you, ma'am, for the wonderful session. I request Dr. Vijay sir, to felicitate Mridhi Tiwari, ma'am. Thank you, ma'am. Thank you, sir. Moving on to the next session. The next session is on management of dog bite in pediatrics by Dr. Shrikant Zamdade. He is the Assistant Professor, Department of Pediatrics, SAGE GSMC and KEM Hospital. He is also a consultant in Genetic Clinic, Learning Disability Clinic, and Pediatric Intensive Care Unit in KEM Hospital. He is an executive board member of Indian Academy of Pediatrics, IIT Mumbai, and also a member AEFI Mumbai. We welcome you, sir.
Thank you so much. Good afternoon, Dr. Vijay Kumar sir. Good afternoon to all senior faculty, colleagues and students. So I think most of the things that I had planned to talk about have actually already been covered. So probably my talk is going to be a short one. So rabies is seen in over 150 countries worldwide with 60,000 deaths per year. And out of these, 1/3 of the deaths, they occur in India. So almost 18 to 20,000 deaths due to rabies occur in India. And out of these, almost 30 to 60% of the deaths occur in children 5 to 15 years of age. The rabies deaths are 100% preventable through post-exposure prophylaxis. But the lack of awareness that one should take medical care after the dog bite and the cost are the main hurdle for the people to get the access to post-exposure prophylaxis. According to WHO, the cost of rabies post-exposure prophylaxis is $180. Children are more likely to be the victim of animal bites for the natural reasons because they are exploring their environment. They are not scared when they are supposed to be scared at times, and they are sometimes they will provoke or touch the animal who is just lying, and animal will give its reaction. So approximately 42% of the dog bites they occur in children between 5 to 15 years, and the male to female ratio is 1:2. As Smriti madam told, children are more likely to get bite on the head and neck region. So younger the child, more likely that the bite will occur on the head and neck and the trunk. The older children, they will get the bite on limbs. Size of the dog, does it matter? Yes, because the size of the dog, severe injury, likely that the injury will happen to head and neck. But a small puppy can also transmit the disease. So every dog bite is a potential for rabies, and post-exposure prophylaxis is indicated. Vaccination status in the dog. So this is a common question that parents will ask. The dog, he has got a bite from neighbor's dog, but the dog is vaccinated. So does the child require vaccine? So the answer to it is the vaccine efficacy may not be 100%, or there may be some problems in vaccine administration, or the animal's health itself may not be good, and the vaccine, um, the the dog may not have developed the immunity. So in that case, even if there is the pet dog is vaccinated, even in that scenario, the post-exposure prophylaxis is indicated. Again, provoked and unprovoked bite. So a rabid dog is likely to bite without any provocation, so unprovoked. But that doesn't mean that a provoked bite is, it is not necessarily non-rabid. And contraindications. So if, as we say that child is, if we bring the child to immunization, sometimes if the child is having some undercurrent illness, although it is not advised, but sometimes we say, okay, we can take it after few days, the vaccine. But here there is no contraindication like that, and intercurrent illnesses or even whatever may be the age of the child, however younger, if there is a animal bite, dog bite, then post-exposure prophylaxis is indicated. So Dr. Smriti Madam has already covered this in great details, so I'll probably skip this. These are the three categories, and the management: wound care, rabies immunoglobulin, and rabies vaccine. These are three aspects of the post-exposure prophylaxis. And wound care is the most neglected part of these three points. And one must remember that wound care is very important. It is equally important as the vaccination and immunoglobulin. So whenever there is a dog bite, without wasting time, we should take the victim to a place where the wound can be thoroughly washed. If there is no soap and water, whatever there may be next, suppose there is a running tap but no soap and water, take the patient there and keep the wound under running water for at least 15 minutes. Of course, if soap and water and antiseptic is available, obviously we have to use it. I still remember in my undergraduate days, when our professor had taken, microbiology professor had taken lecture on rabies vaccine, rabies virus. So he had told that you take the victim to the washroom, take a soap and keep washing till the soap cake finishes. I still remember. Okay, so that is what he had told, and that will take care of the, means that it has a potential to take care of the rabid dog bite. So that is what our professor had told. So madam has already covered these points, so I will skip it. So how to prevent animal bite? So these are a few points. Do not disturb any animal that is sleeping or eating or feeding her puppies. Do not approach or touch an unfamiliar animal. Never run or stare seeing a dog. Keep calm and walk without looking at the dog. Do not provoke a dog on the road. Allow the pet, even if it is your pet, if you go and from behind and touch the pet, he doesn't know who has come, and he might have his reaction and he will turn and he'll bite. So allow your pet to see you and sniff you so that he knows that this is my owner or he's a familiar person, and then that type of incidents will not happen. And children should be sensitized to develop a humane and compassionate attitude towards animals, and they should be aware about the basic safety tips. How to control stray dog population? This is advocated by Indian Academy of Pediatrics. So educating the pet owners, dog registrations, dog vaccinations, sterilization and rehabilitation of stray dogs. Animal birth control of Government of India has recommended castration of male stray dogs and hysterectomy of the female dogs. And feeding the dogs, stray dogs should be curtailed. That is very important. That KM also there are multiple dogs in all the everywhere in all corridors. The main reason is that the patient's relative who come for the treatment, while they are having their lunch or their meals, they feed the dogs and cats. If that is avoided, then we can have at least KM free of stray dogs. And practice of abandoning the puppies should be discouraged. So this is not a cat. Sorry, this is not a dog. This is not a dog. This is a cat, a big cat. So these are few numbers, thought-provoking numbers. So there are 20,000 deaths those happen in India, and the dog population in the world is 90 crore dogs are there in the world. How many deaths occur due to tiger bite? The tiger doesn't bite and stay there. Isn't it? So how many deaths occur due to tiger attack? Anybody can tell? Any guesses? So there are 5,500 tigers in the world. So all these numbers which are there on the screen, the human beings are responsible for those numbers. Now 90 crore dogs are there in the world, which is in a way causing those 20,000 deaths in India. And there are 5,500 tigers in the world left. And human beings are responsible for that. So this is what is the real reason behind the deaths is this is what human civilization has developed, which is more pro towards dogs, and they're destroying the tiger's habitat. So the answer to the question is almost 50 to 110 tiger attack deaths happen in India per year. Thank you so much.
Thank you, sir, for your session on management of rabies and pediatrics. I now request Dr. Y.B. Chavan, sir, to felicitate Dr. Shrikant, sir. Moving on to the next session, the speaker is Dr. Ravindra Devkar, sir. He's an additional professor in the Department of Forensic Medicine and Toxicology at Seth GS Medical College and KEM Hospital. Sir is also an editor-in-chief for various multiple national and international journals and has over 40 national and international publications. Sir has completed his post-graduation in forensic medicine and master's and bachelor's degree in legislative law and is also a FIMA fellow. Sir is also a dedicated member, contributing to numerous committees at our institute through his invaluable expertise and leadership. I welcome you, sir, for your session on medico-legal aspects of animal bite.
Good afternoon, all. So at the outset, I'm thankful to our patron, Dr. Sangeeta Rawat Madam, our organizing president, Dr. Vijay Kumar sir, our organizing secretary, Dr. Amit sir, to provide me this opportunity to talk with you in this multidisciplinary CME on rabies. So you know, whatever happens, at last things remains with medico-legal aspect. And nowadays, these things are very, very important because as a humanitarian approach, being a doctor, we always think treatment at first. But beside providing treatment, managing the case very well, abiding our own expertise, our own field, we have a legal binding on us to have appropriate medico-legal undertaking and properly documenting each and every aspects. In addition, some sample preservation and further needed things. So as this is one of the important topic for our day-to-day routine practice at hospitals, and hence I think at the end, besides a very good talks till time, this is one of the important topic you need to see. So in this today's topic, I am going through these important points. So bite mark analysis, medico-legal aspects, including medical management and legal implications, liability, negligence, scientific evidence and expert testimony, and punishments. So this medico-legal aspect of animal bite involve intersections of medical evaluation, legal consideration, and forensic investigations. This bite mark analysis is helpful for a variety of legal cases such as homicide, sexual assault, child abuse, and animal attacks. Bite mark analysis plays a crucial role in reconstructing the event preceding an attack. So in such cases, this bite mark evidence can provide valuable information that can help to establish the identity of perpetrator and strengthen the prosecution or defense case. However, it is essential to note that bite mark evidence can sometimes subjective and prone to error, and it is crucial to rely on scientific methods, and trained forensic experts have to ensure the accurate conclusion. So these bite marks, these are the pattern or impression left behind by teeth, often found on human skin or other body tissue after a bite. In medico-legal context, so bite mark can be defined as a physical injury caused by a human or animal bite that can be used as potential evidence in legal proceedings. And the analysis of bite mark can help to determine identity of the biter and assist in the identification or elimination of potential suspect in criminal cases. So bite mark analysis, how it is done. So there are various methods. One is photography. So with photographic appearance, you can prepare dental casts, and next is digital imaging. So in comparison, just the features that are on the skin and jaw is compared. This is second method, casting. So dental casts are made and accordingly the comparison done with particular wound. And third is digital imaging of that particular wound. So these are helpful as a evidence in court of law to compare and to confirm the perpetrator. So the analysis involves examining the size, shape, pattern of bite marks, the degree of tissue damage and healing, the presence of specific features such as tooth marks, abrasion, and bruising. So the injury examination, writing the injury appropriately, all things are very important, and basically this is done by CMO or who is on duty in surgical department who is managing the emergencies. So appropriate finding need to be documented by that particular on-duty doctor. The analysis can also provide information in regards to the direction and angle of bite, the number and spacing of teeth involved, and any other relevant details which will helpful to identify the biter. So these all things should be specifically mentioned by on-duty doctor in regards to the bite mark, whatever found on particular case. Then whatever bite mark come to us, you need to differentiate between is it a human bite or animal bite. So some differences related with this. So at that time, you being a duty doctor may not need to differentiate, you just note down your findings. So depending upon that, expert opinion can be taken from forensic in regards to the type of that particular bite. So human bite, mostly broad, U-shaped, and animal bite is narrow at anterior aspects. Arch, it is circular or oval in human, it is V-shaped or elongated in animal bites. Teeth are broad central and narrow lateral incisor, more blunt. So in animal, they are broad lateral, narrow central, sharper and longer canines. And these canines lead to some avulsions also. Then injury pattern, so commonly bruising, lacerations and avulsion are less common in human bites. So there is a local bruise. So it's just pressure abrasion or local bruising at the site of bite. But here severe lacerations and avulsions and greater skin damage seen in dog bites or animal bites because the canines are longer one, and if they inserted and they are going to pull the skin, so that leads to severe lacerations. Site, so these human bites mostly on breast, abdomen, thighs, back and shoulders. Here extremities are involved in animal bites. Some examples, so these are dog bites. So pictures. So this predator goes for vital regions of face, neck, so extremities and external surfaces are involved. Small children are more vulnerable in this case, and tearing of flesh due to biting and pulling of the body parts is observed. Cat, these are smaller than dogs, attack approaching body parts, sharper canines for puncturing, but weak teeth do not pull on the body parts. So lacerations are rarely seen in this cat bite. They grab hold with claw. So they just grab this thing, and hence there are abrasions found in that particular bite. 2 or more puncture wound due to canines may be seen. Bears or big cats, so large predators, attacks vital regions, mainly head and neck. Massive lacerations, avulsions are seen, and frequently it becomes fatal as there is a bleeding, and mostly face and head is involved. They attack with their large claws. Common in forest area, hilly farmlands and around nature reserves. Then next is snake bite. So they attack mostly bare areas. So feet, lower limbs are involved in these cases. Usually happens at night. And two tiny puncture wounds are seen in this. Specifically, there are two red areas seen on foot extremities. So mostly snake bites are suspected. They are neurotoxic or hemotoxic. So accordingly, signs and symptoms are seen. Scorpion sting. So mostly on exposed body parts, there is an extreme local pain. Single tiny puncture wound is observed. In snake bites, two puncture wounds are seen. Here, a single puncture wound, erythema swelling around that particular puncture wound, and there is a local tissue necrosis. Abrasions due to this pincer grip may be present surrounding that particular sting sites. And these red scorpions are deadly, so fatality is there with red scorpion bites. Then again, one of the most important medical legal aspect is what is antemortem bite and what is postmortem bite. So if things are fatal, there is a death, so we need to give opinion, is it antemortem or postmortem? Because many times if the body is in the home or in forest, there is a nibbling and there are postmortem bites generally seen on the body. So there are certain artifacts. So difference, so it is similar one related with antemortem wound and postmortem wound. So physical response is inflammation, bleeding, clotting is observed in antemortem, which is not observed in this postmortem. Bite, wound, tissue reaction, bruising and hemorrhage seen. Lack of tissue reaction, tissue decomposition. Here, decomposition, scavenging signs are seen. So the postmortem color changes and other sign gaseous formations, etc. are seen. And forensic implication, here medical attention is necessary while in time of injury relative to the time of death, and that need to be given by forensic expert at autopsy. Then these are some examples of postmortem bites. So pet cats, dogs, mice, etc. scavenge on their owner's dead body out of hunger if that is left in the locked home for long time. Animals in the wild scavenge the dead bodies, and teeth marks or bone in and around that wound will be assessed, and accordingly the opinion is given at the postmortem examination by forensic expert. So medical legal aspects. So medical aspects, as every physician need to give appropriate treatment with respect to whatever case is received. So medical management is discussed in all these 4 lectures. Legal aspects. So at the same time, while providing this medical management, we need to document the things appropriately. So history and everything should be mentioned, and especially injury to be documented. If possible, you can draw a diagram, etc. So that will be certainly helpful in further giving appropriate opinions. At the same time, you need to take certain samples. So with respect to different cases, this sample collection, preservation and dispatch to be done as per protocol. There is a form number 2 for sending all these samples. So in our medical legal aspects at hospitals, all these things are told, how the form number 2 to be used, how these samples to be preserved and dispatched. Then there are certain legal implications and liabilities and negligence by the operator, negligence by the person who is using these pet animals. So initial management, I'm not going in details. So clean the wound, stop bleeding, apply antiseptic, medical attention, tetanus shot, and monitoring. Snake bite, initial management, stay calm and still, immobilize affected area, remove tight clothing and jewelry, avoid harmful actions, and you should not apply any ice. No need to cut, no need to suck the venom, no need to apply tourniquets, and seek immediate medical help. So this is guide for post-exposure prophylaxis. Taken details already. Then legal aspects. So as I said, you need to document all injury in detail. Afterwards, you can send a call. So bite mark analysis can be done. It will help to find the species, match the suspected animal. Saliva swabbing of bite mark should be taken by on-duty doctor. So it will help to detect the non-human DNA and helpful to differentiate between human bites, animal bites, and further confirmation with that particular perpetrator. Collecting stray hair from or around the wound. So if such foreign bodies are available, accordingly they are collected and their morphological studies and species studies may be done. So this is, so you have to take the swab, so that will help to match with saliva, and there are difference between hairs. So human hair are differentiated from animal hair. So if you preserve that particular human hair or foreign bodies, you can, it will help for further identification. So additional medical documentation, so photographic evidence to be kept, medical reports, all these things should be maintained appropriately, and mandatory reporting. So in many jurisdiction, animal bites must be reported to local health authority or animal control agency. This is crucial for tracking incidents and managing public health risk. So case studies and historical data, so behavioral patterns and epidemiology data, that will be certainly helpful. Animal bites can provide vital information in criminal investigation and legal proceedings. So identification and analysis, again, this bite mark analysis for pattern recognition, comparison, dental impression to be taken, and at last with this swab taken from that particular site will helpful further DNA extraction, and this DNA analysis will be further helpful. So legal implications, so there are cases using animals to cause murder, so murder, assault. Another thing is negligence. So owner of domestic animal like dogs can be held legally responsible if their pet bites someone, especially if animal is known to be aggressive. So it's responsibility of that particular owner. So this section 291 of Bharatiya Nyaya Sanhita is related with this. Anyone who knowingly or negligently fails to take proper precaution with an animal in their possession to protect against a probable danger to human life or grievous hurt from the animal can be punished with imprisonment of 6 months, and there may be fine up to 5,000 rupees, and both imprisonment and fine. Civil cases, compensation to be given, and accordingly the monetary compensation to be given depending upon the pain and suffering. So there is Uthara case, which is a famous case where husband Suraj Kumar confessed in public media that he purchased a cobra, and that snake is introduced in the bedroom of her wife in intention to kill her. So again, death, injury by police dogs, etc. So this compensation should be given in all these cases. Then public health consideration, so rabies and other infection. So rabies control, infection risks, animal control measures to be done, quarantine, euthanasia, public awareness, and community programs, which are already discussed. So there are 23 breeds which are aggressive, and these are dangerous one, which is not allowed in India. So this is the list of 24 breeds. So this Prevention of Cruelty to Animals Act 1960. So here it defines animals. So this act prevents the infliction of unnecessary pain and suffering to animals, and they work towards animal safety. So it's illegal for housing society to establish pet bylaws that forbid pets, even with the supports of majority. So this is not allowed. Then if there is a death, we need to do postmortem examination. So if death is due to rabies, usually postmortem is not done. We are going to certify the body directly. So there is a circular. All these infectious, highly infectious cases, postmortem is not done. Only postmortem is done if there is some additional unnatural thing. So if there is additional road traffic accident, or the cause of death may be different from rabies, and which is unnatural. So then with all safety precautions, PM is to be done. Then death due to snake bite, PM is always done, and special viscera preserved, the skin from bite site, and other viscera is sent for immunological reactions. So take home message, there should be appropriate initial care and medical management, and besides medical management, considering the legal implication, you have to maintain appropriate medical documentation, need to collect the sample and send it for further analysis. There should be post-exposure prophylaxis and the liability accordingly. So if you are owner of the pet, you are liable for whatever consequences happens due to it. And sometimes if you have done some mistakes at medical documentation, again you are held liable for this. So thank you. There should not be any issue in future with you when you are on duty. So you will do appropriate medical documentation and preserve appropriate samples. So minimum that thing is expected from you. Thank you.
Thank you, sir, for the wonderful session. I request Dr. Vijay Kumar Singh to felicitate Dr. Ravindra Diokar. Thank you, sir. Moving on to the next session for the day. The topic is Canine Rabies Control, and the speaker, Dr. Chandrakant N. Galdar. He is an assistant professor and radiology safety officer, Department of Veterinary Medicine, Nuclear Medicine, and Radioisotope Laboratory, Mumbai Veterinary College, Parel, Mumbai. He has numerous academic achievements, which includes Dr. Sushman Roy, ISBM Gold Medal for the Best Teacher in Veterinary Medicine, and he has been awarded the ISBM Appreciation Award 2020 and also the INTA's Young Scientist Award in the year 2005. He has numerous publications in national and international journals and has authored 2 chapters in the book for veterinary medicine. Over to you, sir.
चेंज करने के
Good morning, one and all. Am I audible? Yeah. It's really a matter of great pride. It means feel very honored to be a part of this auspicious gathering, because here I am representing my veterinarian role in control of rabies. I sincerely wish to acknowledge my institute for permitting me to deliver the talk on rabies control. I'm also thankful to my team who is working in veterinary aspect of rabies control, where Dr. R.V. Gaikwad, he is a professor of Department of Medicine. Dr. Vosley is working on the rabies. Dr. Tatelu, she is this veterinary officer at BMC. Dr. Mayur, he is hospital manager at SPCA Hospital. And Dr. Farande, he is the microbiologist working in the field of rabies. So to start today's talk and role of veterinarian, just I would like to quote one important quote given by Madam Curie. It is nothing but, nothing in the life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. Actually, this quote is applicable for radiation or radioactivity, but I feel that this quote is also applicable for control of rabies. We know that rabies is 100% fatal, but of course, rabies is 100% preventable. So if we have idea about the prevention and control strategies of rabies, we can definitely prevent its occurrence in the human being also. Again, in earlier lectures or earlier speaker, the human doctors are concerned that zoonotic importance of the rabies is most important, and where veterinarians, they are at first risk because they are handling the clinical cases which are suspected for rabies. So if we have an idea about the control of rabies in animals, we can do a impressive control of rabies in human being. So this quote is applicable for role of veterinarian and role of human doctors in prevention and control of the rabies here in India. I will not take much time on this basic slide of the rabies, but here in animals also we are getting furious form and dumb form. And as far as the hydrophobia is concerned, in animals, hydrophobia, or especially in canines, hydrophobia type of the symptoms, they are not generally presented when we are handling or when we are seeing the clinical cases or suspected cases of the rabies. Now, this is the most important slide where we can see every stray dog bite should be treated as a rabid dog bite. It's question mark. Now we need to think, because the aim or this title of today's CME, that we need to rethink about the rabies. At the same time, we need to come up with some solutions or modern solutions so that we can do an impressive control of rabies, not only in animal, but also in human being. So just I would like to quote a recent studies where 156 saliva sample were collected and they were analyzed for RT-PCR, and in that 14 samples were positive. And these samples were from unvaccinated stray animals. So this is the alarming that yes, this slide need to be reviewed very critically or very crucially. Now, as far as the role of my institute, I am representing my Mumbai Veterinary College. This college is hardly 5 minutes away from this institute. This college is the oldest college established in 1886. And we are working with the affiliation with the Sakrabai Dinsha Petit Hospital, where our doctors are treating the clinical cases admitted to the hospital, animal hospital, where almost 400 to 600 animals, they are admitted for treatment. Now you can see what are the challenge we clinicians are getting when we are suspecting or when we are seeing the clinical cases or when we are suspecting the cases they could be associated with the rabies. In earlier lecture, some speaker, they told that nowadays in Mumbai, dog lovers, they are getting in it means their number is going to be increased in intensify manner. Their number is going to be increased in intensify manner. This means that if we educate the dog lover, I think 90% of the prevention control strategies we may able to implement very efficiently. So whatever the clinical cases are there, whenever stomatitis clinical cases are there, during that time, and especially stomatitis clinical cases of stray dog, just I would like to bring your notice that there are three type of the category of the dog. One is the stray dog, where dog they can roam around. For example, 5 or 10 kilometer area, they can roam. After that, community red dogs are there, where some communities are there, they are offering the food, they are living in the society. And third is domesticated or pet dog. When we are getting the suspected cases with the pet dog, no doubt in the pet dog, it means sporadic incidents could be there. But as far as the dogs which are stray dog, during that time we are getting a challenge for its assessment or for its inspection, where stomatitis may or hypersalivation going to be caused by the stomatitis may misguide us, that whether it could be a availability of the clinical case of the rabies or it could be a clinical case of the stomatitis, especially in stray dog, where history is unknown to dog lover also or the person who is taking that patient to the veterinary hospital. Again, as far as the large animals are concerned, in ruminant, there is ovine ketosis, where the nervine symptoms are resembling as like the rabies. So that differential diagnosis is very challenging in a clinical cases with excessive salivation or availability of the excessive nervine form is there. So that we need to be tackled with the careful history and inspection of the ailing animals. Now, as far as our approach is concerned, here, when our patient they are presenting at our outpatient department, TVCC is nothing but teaching veterinary clinical complex or our animal hospital. Generally, the clinical cases or suspected rabies cases, they are presented in odd hour. After 12 o'clock, these animal lovers, they will get, it means they are wake up, and when they are going to be see some abnormality, especially salivation, they are taking up that particular animal and just presenting in front of the OPD doctor or the doctor who is doing duty in the odd hour. So our approach is that we are suspecting the clinical cases on the basis of the history. Here, three categories of the dogs are there. When the stray dogs are there, we are very much concerned about the history taking. At the same time, we are asking the history about the any rabid dog has been bitten to that particular animal. One, again, this dog is protected with the pre-vaccination or not. These are the two most important points. They are helpful for us to ascertain whether presented animal can be suspected for the rabies or not. When we are suspecting on the basis of the clinical finding at the same this inspection finding, not clinical finding, inspection finding at the same time history, we have suspected case. We are keeping they are under observation almost for 2 weeks. We have a separate ward for rabies isolation where we are going to keep the animal there for 2 or 3 weeks with ample supply of the water and food. Now, this is the picture you can see. Okay, this is the picture. This is the veterinarian. Okay. Now, when we are getting the importance of veterinary activity in rabies control, you can see just review of the control activities, that is rabies control activities. When first that 11 national development plan was there, which was implemented in year 2007 to 2012, where emphasis were given on rabies control in animal, second, animal birth control, and third, vaccination of stray dogs. It means veterinary activities or animal husbandry activities comes in picture. So, and the objective of this to eliminate the or control the rabies in humans, and considering the animal rabies control activities, animal and vaccination. So these are the project of objectives, and when they have taken all the aspects in consideration, they come, it means their results were whatever the strategies they have developed, it is feasible, it is reproducible, and it can be implementable. And same they are implemented in next 5-year plan, from 2014 to 2017. So we are getting impressive control over the rabies. Earlier we can see that 80,000, 90,000, but now today I have seen some presentation, they are reporting 60,000 clinical death going to be arise because of the rabies. This indicates that yes, whatever the implementation plan we adopted, it is giving impressive control over the rabies. Now we can see rabies and One Health. We know nowadays One Health approach, it is demanding, and this approach is really doing an impressive miracle as far as the control of many infectious diseases. When we are going to see the One Health approach 5 years back or in its infancy or in initial days, people don't know about the One Health approach. It means people won't have idea about what is their role in One Health. But now medical practitioner, they are getting very good idea that what role they can able to play in control of prevention and control of the infectious diseases or the diseases like rabies. At the same time, veterinarians, they are now come in front and they are also making their, or they are also contributing as far as the prevention and control of the rabies is concerned. So here, just I would like to highlight the role of veterinarians in One Health and rabies control, that dog animal population control can be, it means applicable, or that can be just tackled by the veterinarian. Then mass dog vaccination, then education on the rabies. This is most important. This is most important. Until and unless we are not going to be educate the people as far as the rabies is concerned, I think we may not able to successfully eliminate this particular disease from India. Then reporting of human and animal rabies cases data sharing across the human and veterinary sector. As a clinical practitioner, I personally feel that human doctors and veterinary doctors, they need to have a joint hand as far as this fourth aspect is concerned, where reporting should be there. Whenever any clinical human case is available with you, you need to see what is the origin of that dog bite, and you need to take the, it means custody of that particular nature from the veterinary facilities available across that territory. Now, this is the successful model of One Health, where the role of human doctors and role of veterinary doctor is successfully implemented. This is the One Health approach, and this approach is implemented in year 2002. This is the pilot study 2022 by scientist Catherine, and where they have developed 6 components. At the same time, they have developed the flow, where 6 components. Component number 1 is report and exposure event. Then component number 2 is perform risk assessment. Component number 3 is trigger animal investigation. And this is the most important role of a veterinarian, where you can able to say that conduct the animal investigation, where we can able to say if animal is healthy, keep this particular animal under observation for minimum 2 weeks or 14 days. If animal is died or expired or euthanized, you need to do a collection of the sample and its proper diagnosis. And after that, the point which I was highlighting, this sharing of the reports or sharing of the data is equally important, so that each and everyone, it means veterinary field also and human field also, get an idea that what could be a factors responsible for spread of this particular disease or this activity in that area. Now, what is the current mission? The current mission is setting a global goal of 0 human dog mediated rabies death by 2030. This is most important, and this we need to achieve, and we are, it means I'm damn sure that by 2030 we will control or we will eliminate this particular disease from our beautiful country. Here the National Action Plan, that is NAPRE, is there. It is nothing but National Action Plan for Dog Mediated Rabies Elimination from India, and this is going to be implemented by animal birth control. It is called as ABC activity. Then mass dog vaccination, then rabies surveillance and rabies education. This Mumbai Municipal Corporation also, they are also making the joint hand with our veterinary college, and we are implementing these particular activities. The animal birth control, here 2 things are there. When we are It means just discussing animal birth control in this hall. It looks very easy. But I told that challenges are associated with the stray dog. So when your stray dog animal birth control is there, during that time, we are using CNVR program. C means capturing, N means nutriting, then vaccination, and we need to release that particular animal in that. During that, we need to do a marking properly. When owner dogs are there, they can easily understand the importance of rabies control or importance of vaccination, diseases and all. In that, we will not get any difficulty. Now, as far as the mass vaccination program is concerned, it is mandatory that more than 70% of the dog population should be vaccinated. We need to do a post-vaccination surveillance. At the same time, we need to see whether 70% of the animal they were vaccinated or not. If they are not vaccinated, we need to reassess or redo the vaccination program again. Then rabies surveillance, yes, it is most important, and rabies education. It is also equally important. So I'm very happy that Mumbai Veterinary College, we are working in One Health approach, and we are also making awareness that this celebration of the rabies day is there, World Zoonosis Day is there, where we are doing the mass vaccination. At the same time, we are publishing the pamphlets for the dog owners who are associated there. Now, there are certain strategies for animal health component with special reference to One Health and rabies control. So I will take this reverse way. 10 number is operational research. Yes, we need to have operational research so that involvement, or we need to see from where the disease is going to be originated. That tackling or that controlling is most important. Then confinement and contaminant. Yes, if rabies affected animal is there, as per the sir has just earlier speaker, he has mentioned about the rules and regulations about the animal disease control. So that need to be implemented. Rabies is the notifiable disease. We need to just keep that animal under observation, or we need to keep it under the confinement. Then community involvement, yes, tier 1, tier 2, tier 3, all the people need to be considered whenever we people are involving them in this control program. Solid waste management, it is nothing but we have seen that whenever the foods are available, we can see that maximum dogs, they are going to be attracted there. So solid waste management for our canteen people, we need to say that yes, proper solid waste management you need to implement so that maximum dogs, they should not be attracted. Then to promote the responsibility to dog ownership, yes, they need to be educated about the vaccination. They need to be educated about the importance of the deworming. They need to educate about the importance of this health management and all. Then dog population management, I told. Then assessment of the post-vaccine coverage, as like in human being, in veterinary also, it is equally important. Then planning and implementation strategies, mass vaccination that we have discussed. Identification of the rabies risk zone is most important, so that we can see what is the origin of the disease or where we are getting the maximum reporting of the rabies cases, and estimation of the canine population. So these are the animal health components that every veterinarian in collaboration with the human doctor and other components or stakeholders available in the One Health can implement for control of this rabies. Thank you very much for your patience hearing and giving me chance to be a part of this auspicious gathering. Thank you very much. Thank you. Just a minute. Just 2 points I have noted during the earlier speaker. That is category of the wound. One speaker he has told about the category of the wound. So here in our veterinary, the category of the wound, first, second, and third, maximum cases in domestic animal we are reporting. The bite of the dog is at the head region, especially at the muzzle region or especially at the mouth region. So they need to be considered critical. Other regions are there. We can get an animal bite at the tail region also, but comparatively bite of the dog at tail region and comparison it's with the bite of the dog at mouth or at muzzle region, that is considered as the more critical, and it need to be treated or it need to be attended very aggressively as compared to the level 3 or level 2 or level 3 is concerned. That just I would like to just update what are the notes I collected during the presentation of other people. Thank you. Thank you.
Thank you, sir, for your elaborative and wonderful explanation on rabies control in canines. I now call upon Dr. Mridula Solanki ma'am to felicitate Dr. Chandrakant sir. So moving on to the final session for today's CME, I call upon the speaker, Dr. Deepika Sadavarte ma'am, Assistant Professor, Department of Community Medicine at Seth GS Medical College. Madam is a member of various international bodies and is the recipient of Dr. Chandrakant Patil Award for Best Community Work and Mr. Prabhakar Rege and Mrs. Rekha Rege Institutional Award for highest marks, and has over 29 publications in various national and international journals. Madam has expertise in the fields of travel health, immunization, maternal and child health, and is an advisor for animal bite cases. She was a key person in organizing the CME on rabies from pasture to present in 2016 and has worked in rabies vaccination and is the nodal officer for yellow fever vaccination. She has been an author to research in rabies on health-seeking behavior, compliance to post-exposure prophylaxis, and out-of-pocket expenditure of victims of animal bite. We welcome you, ma'am, to present the current status of vaccines and their future perspectives.
Thank you. So the most important fact that I have to remember is I'm keeping you all away from your lunch. So bear with me for maybe next 15 minutes. So the session that is given to me is on rabies vaccines, the current perspective and the future. So I think a lot has been spoken about the current vaccines. Some of us are using them in our ARV OPD. So I'll be just brushing through that and maybe more concentration on the future and some live experiences or the cases that we face in our day-to-day dealing with rabies patients. So I intended to, take my session under following heads, but I think some of it I would like to, omit now so that, we save on the time. So there are 4 facts which, all of us have to remember when we talk about rabies. Most important, it is 100% fatal, but it is preventable, 100% preventable. Second, the vaccine that has been developed, it can prevent rabies even after exposure to the virus. The first vaccine, always remember, most of the first vaccines, they were developed before even the cause of that disease was known. And as my previous speaker said, that we can achieve zero transmission if it is controlled in the animals. So what is the most essential thing when we, think about vaccine? Yes, I would like to have some interaction from the audience so that I can keep up for next 15 minutes. Yes, what do you expect a vaccine should be? How a vaccine should be? Anyone? Affordable, okay, very good. Effective? Least adverse effect, okay, yes, you don't want side effects. What else? You need it to be more effective, right? And rather in terms of cost effectiveness also. So whenever we talk, the people who develop vaccine, they think about these 3 things. One, that they need to get a highly purified, well-tolerated product with a good safety profile. It has to be powerful. It has to be potent with early, long-lasting protective titers and highly efficacious, and has to be trusted with all the possible regimens that you have. So taking you all back to the history, how it was developed, I think a lot has been spoken about Louis Pasteur and Emily Roux. So this is how in 1885, the first vaccine was developed, and we give the credit to Mr. Joseph Mister, who was just a 9-year-old boy with a dog bite at that time. And he was inoculated with 13 injections that eventually saved him, and that's how the vaccine came. These are some other vaccines which have been worked upon all through different years. So we have the Semple vaccine in 1911. Then the next notable were the chick embryo cell vaccines in 1985. 1992, we started having really cost-effective vaccines and replacement of the neural tissue developed vaccines. So in 2001, WHO recommended phasing of the nerve tissue vaccines in all the developing countries. So looking at our own country, in 2005 and 6 is the period when we started using the intradermal regimen of the vaccine that we have. So in brief, this is how the timeline went. We started with the first generation vaccine, that is a Pasteur vaccine. Then came the chemically modified ones, Fernie and Semple. Then we started developing myelin-free tissue vaccines because myelin had a lot of side effects. The neural tissue vaccines had a lot of side effects. Embryo vaccines, and what we are dealing today are the second generation vaccine, the cell culture vaccines. Another major shift that you must have heard कि अगर कुत्ता काटता है तो पेट में 14 injections लेने पड़ते हैं. So we have shifted from the intramuscular injections which were given on the abdominal wall to a very wonderful regimen of intramuscular and intradermal. So why intradermal? Most importantly, it turned out to be very cost effective. So in 2005, the vaccine supply was inadequate for the cell culture vaccines, which were given intramuscularly, and there was a severe shortage. So that was a time when there was a felt need of some vaccine, which can be used very effectively, as well as it is cost effective and easy to give. And so in Jan 2006, APCRI President and Secretary General, they represented to our health minister for implementing this intradermal regimen of vaccines. So the scientific basis of using intradermal is it is the most effective way to deliver. Of course, there's no difference in intramuscular and intradermal regimen, but it is more effectively delivered because of the cells, the Langerhans cells that we have in our epidermal layer, which takes it to the nearest lymphatic system, and soon the response is started. So this intradermal rabies vaccine was approved by WHO and DCGI in Feb 2006, turned out to be very cost effective. Safety-wise, efficacy-wise, it was one of the best method of delivering the vaccine. The only glitch here is you need training. So that bleb has to come really beautifully. I think you can see in the picture here. Vaccine vials stored in +2 to +8 range. And after constitution, we have to remember that we have to discard it after 6 to 8 hours. So a few vaccines which are there in the market. Okay, most of us have heard these names now all throughout the sessions. Rabipur, Indirab, Virorab, Abhairab, Vaxirab of Zydus, of course. And this is what we have rabies vaccine in our KEM casualty. So this is in the MCGM supply, which is from Human Biologicals Limited. Indirab is another one which is there in the government. So in GMCs, you will find Indirab which is used. So whenever we talk about vaccination in rabies, it is either pre-exposure or post-exposure. So in pre-exposure, we have certain high risks, where you need to take a pre-exposure prophylaxis, like the laboratory staff which are handling the rabies material, or the patients, veterinarians, animal handlers, wildlife wardens, travelers, whenever they travel to rabies endemic country. And the Indian Association of Pediatrics has recommended PEP for children, as earlier speakers said, that children are more vulnerable. But even today, it is just on voluntary basis, and it is not a part of our immunization schedule yet. So in pre-exposure prophylaxis, we have 2 schedules, okay, which is 3 doses. Intramuscularly on 0, 7, 21 or 28, and intradermal on 0, 7, 21 or 28. The high-risk groups should ideally check their titers every 6 months in the first 2 years. Booster if the titer is less than 0.5 international units, and sero monitoring every 2 years. So this has to be religiously done by those who are in high-risk groups. Previously vaccinated individuals who have got pre-exposure prophylaxis and has now got a dog bite or animal bite can take a booster of 2 doses, on day 0 and day 3, and there is no need of rig in such individuals. So this is what we use the intradermal schedule currently, which is also called as the updated Thai Red Cross regimen. Okay, or it's already been talked about. So day 0, 3, 7, and 28, 2 doses, 0.1 ml. The preferred site is the deltoid, but if at all you cannot give on the deltoid, then I think Smriti ma'am has already told you the other places where you can give. The intramuscular regimen, again, we have an Essence regimen and we have a Zagreb regimen. So either of the two, the Zagreb ones is a faster one because it finishes just in 3 days, whereas for Essence, the patient has to come for 5 days. Intramuscular route is preferred in immunocompromised conditions. So people with immunosuppressant drugs, cancer, chemotherapy, therapy on chloroquine, the malaria therapy, they need to take intramuscularly because it is delivered faster and effectively through that route. This was something very interesting that I came across. It's a global market survey which was done for human rabies vaccine by WHO. And it says that the choice of route of administration plays an important role in vaccine affordability. So because we want to give an affordable, accessible, and practical care. So intradermal administration was providing significantly less expensive cost per person than IM regimen, particularly in our urban settings. So this was one of the key findings. Talking about immunoglobulins, I think already a lot has been talked about. I will just show you what are available in the market as of now. So Equirab is something which is very commonly used even in our BMC hospitals. Then we have Favirab, we have Winrab. These are the equine ones, okay? And the human ones, which are of course the costlier ones, we have Suya, Hrig, we have Plasmin, and we have Berirab. This is Berirab. Okay, so these are now available, and of course the human ones are more costly, as told by Dr. Smriti ma'am. What important points that we need to know in practice about immunoglobulins is you cannot give it beyond 7th day. It is no use giving it after first dose of rabies vaccine, regardless whether they have got on day 3 and day 7, because already the antibody response has been started by the vaccine. You cannot give it IV, so it has to be given intramuscularly and around the wound. You can give a wound wash, okay, with immunoglobulin, and can never be administered in the same syringe or the same anatomical site where you give the vaccine. So these are some key points, practical, that we need to remember. So let us go through some practical situations that we face. So this was a patient. These 3 scenarios is what I encountered while working in rabies vaccination OPD. A monkey bite patient received the first 2 doses of ARV on time and also RIG on day 0. Then he defaulted for the 3rd dose. Okay, so he took day 0, he took day 3. However, the patient comes back on day 9. What should be done? Yes, anyone? He has taken day 0, he has taken day 3. Day 7 he missed and he's coming to us on day 9. What do we do? Repeat the schedule. You give on day 9 and okay, so yeah, so you need not interrupt here because the studies say that first 2 doses are the most important to generate a response. So even if the patient is coming to us on day 9, we can give him on day 9, and the last dose has to be exactly on 28th or 21st day, okay? And of course, as madam said, you need to observe the patient. Second case was a boy bitten by cat, received first 3 doses of ARV and RIG in time, but in between 3rd and 4th dose, he gets scratched again by a monkey, which was a category 3 bite. What should be done? Yes, very rightly. So in between, if the schedule is going on and again the person gets exposed, we do not interrupt and restart. We continue the schedule, we monitor the patient, and we tell him or her to follow it as per the days given. Okay, so that is the most important. Yes, you have to continue the original schedule, which is continuing. Then if for some reason we cannot give intradermal, suppose the patient is, there is something on the deltoid and you cannot give him, then which are the alternate sites? Because this is commonly we face. Sometimes a hand is amputated or, fractured or something which we cannot give. So subscapular, yes, and anterolateral aspect of the thigh. Yeah, these are the other two most preferred sites. What you have to remember is the two sites that you're giving injection should not have the same lymphatic drainage system. Okay, that is what one has to remember. A boy bitten by a dog has come to PHC OPD 3 days after bite. Is wound washing necessary at this stage? This is 3rd day of the bite. Someone told him ki jaake dikha do, and he has come to PHC. What should we do? Yes, why? Yeah, one is you're not going to waste water or soap and there is no harm to the patient. But what's the scientific reason behind it? What is there in the wound? Virus. So, yes, so we wash the wound. The basic principle of washing the wound is to reduce the viral load. So you have to wash the wound irrespective of whether he has washed it at home or whether or not he has washed it. So it's always better so that jitna hum virus kam kar sake, we have to reduce the viral load. Now talking about the second aspect of my talk, the newer products that we have to tackle Rabies. So a lot has been spoken about monoclonal antibodies. We have it in market. It's been in circulation, but the only thing is it is still not in the national guidelines for rabies control program. So we still follow vaccine and immunoglobulin, course. So what we have in our BMC settings is Rabies Shield. And of course, today we were introduced to Twin Rab. So we have 2 monoclonal antibodies which are there. What we are using are the inactivated rabies vaccines, okay, which have been in circulation, okay. The recent ones are the cell culture vaccines that we use. Sometimes we have to stabilize these vaccines. So we can use inactivated strains by inactivating agents which are there. The most preferred being the BEI, which is used because it is very stable. But still, after stabilizing, these vaccines are still having lower immunogenicity, they are expensive, and they require multiple vaccinations. So what we are trying is can we reduce the number of doses to maybe a single dose or, a 2-dose regimen like some other vaccines. So then came the adjuvanted. So we know what adjuvants are. They are added to vaccines to stabilize the vaccines and make it more effective. So we have a lot of adjuvants. The common ones are aluminum hydroxide, phosphate, saponin, which are often used. There are some synthetic adjuvants that have been used in the research now. Okay, and such adjuvanted vaccines, the ones which are in the red, these are ones which are going under research so that, one of them can turn out our candidate. The next is the genetically modified vaccine. So you try to modify the gene either through insertion, deletion, or artificial synthesis, or you change a nucleotide sequence through some method. So the ERA vaccine is it's probably in the phase 1 of clinical trial. And these are the other ones which are, being tried as genetically modified candidates. The recombinant vaccines, these 2 are the candidates which we are, working upon. And these are oral vaccines. They are basically for canines. They are not for humans, these recombinant vaccines. One of them has been used as a candidate vaccines for immunizing foxes and coyotes in US, and successfully they have vaccinated maximum population of foxes to avoid canine rabies. Then RNA vaccines are another candidate. Again, they are in the phase 1 of clinical trials. CV7201 is a candidate which is being tested, but the success has not been seen that much. Titers are declined by 1 year after vaccination, so booster effect is not being seen. Then comes the viral vector vaccines. So these are the candidates which are of viral vector. So here some viral vector is used to deliver the vaccine effectively. Coming to the challenges of rabies vaccination. So this was a case that we had where, the child was having bite marks on the face as well as on the scalp. So what do you think is a challenge here? Face and scalp. What's the biggest challenge? Yes? Administering the vaccine, of course, it is very difficult to administer vaccine around the eyes. It's very difficult to administer vaccine on cheekbone. Okay, it is very difficult for administering vaccine, especially immunoglobulin, immunoglobulin on the scalp. Why? Why these places are risky? They are on bony prominences. You cannot push as much immunoglobulin as you can in a muscle, right? So that is why it is difficult to tackle such wounds, and that is why they are high-risk ones. Okay. This was a case of a 5 or 6 years old boy, and probably one of the challenging cases that we face. And the eye was saved luckily, and we had to wash this wound a lot, okay, by diluting the immunoglobulin and as much we could put on his face. And this is after the plastic surgery. So we could save his face, but of course there is a scar which is there. So the other challenges that we face is vaccine related. Of course, sometimes availability, as our previous speakers said, it's not the vaccine, it's the immunoglobulin basically availability because of the cost. Very important is a change. Sometimes you see that patient, change from intradermal to intramuscular. So should we or should we not allow this change? Someone taking an intradermal forgets and maybe reaches somewhere else to take an IM schedule. Should we continue with it? So preferably, we don't change the ID and IM schedules. But in case it's a dire needs, it's a category 3 bite, and you don't want the patient, you don't want to lose the patient from the follow-up, then we may change the route. Okay. Delay in vaccination, very commonly seen as compliance is still very poor. And the compliance is poor because there is lack of knowledge. Okay. So that's why the third challenge is awareness, lack of IEC among public. Compliance, break-in schedule, loss to follow-up are the other challenges that we face. So as one of our other speakers had said, we are trying to achieve 0 deaths by 30. Okay. How many of you know the rabies survivors? How many survivors are there? Are there or are they not? There are 15. Okay. 50. 15. Okay. So Dr. Vaishnav is saying there are 15 survivors. Anyone else? 2. Okay. So, of course, these numbers vary with different news articles that you see. The first survivor basically was Miss GZ. She was around 15-year-old when she got the bite. And for these survivors, what was done basically, they were induced coma. And then all the treatment was done. So it is very difficult to save a patient in rabies, but yes, even science has to deal with miracles. So we have miracles even in rabies. So 0 deaths by 30, it's a global strategic plan. So what it intends in terms of vaccination is we have something called as the vicious cycle of vaccination, wherein we have low demand, that's why low production, and that's why we have a high unit cost. So by creating a vaccine bank, we intend to convert the vicious cycle to a virtuous cycle, wherein we have increased demand, increased production and therefore lower unit cost for per dose. Of course, our National Health Program, National Rabies Control Program, aims to eliminate rabies as a public health threat by 2030, and it also focuses on prompt treatment, animal bites, as well as awareness. So I would like to end my talk by emphasizing two things. If we want to save rabies, first thing is, it is 100% vaccine preventable. So today, as we are aware, we should create more and more awareness about it. And second most important thing is vaccinate to stop the transmission. So it is not just humans, we should also treat our pets, okay? Those who have at home or those who have pets in their family, try to vaccinate them as much as per the schedule. And even for the street dogs, as we have our veterinary partners here, they are trying on their field, to vaccinate the dogs. So I think that will help us curb the transmission. These are my references, and really bear with me because it's a pre-lunch session. Thank you all. Have a wonderful day.
Thank you, ma'am, for that engaging session. I would request Dr. Vijay Singh to felicitate Dr. Deepika. Thank you, sir. Thank you, ma'am. Next, I would like to call upon Dr. Amit Bhulve, Organizing Secretary for the CME, Assistant Professor, Department of Community Medicine, to deliver the vote of thanks.
Thank you, everyone. Seriously, thank you. That's it. Go for lunch. Nahi, thoda 2 minutes suno. Okay. What a day. What 7 days we had toiled hard for this particular academic feast for you all. We made it a point that it aligns with the World Zoonosis Day, so that the message is delivered more clear. And it's a regular thing for us. Whenever a festivity comes, whenever something comes up, and we are all gaga about that thing. So we are all gaga about rabies now, just to commemorate the World Zoonosis Day. So it was a rabies rampage, so many bites, all speakers, probably a bit a part of your brain, bit in the sense, bit part of your brain, and this bite will continue for longer till the time, because I see most of the participants being PG students, it will last longer, that bite will be there. I hope that. So jokes apart, I would really want to thank our dean ma'am, whose leadership and vision always has been instrumental. She has said yes to most of our initiatives, and she appreciated our department. Sir is here, so under sir's leadership, we have been doing that, yes, and we are proud of it. And all of you all who are part of community medicine, I think you all are so active in your departments individually as well. And that's why your activeness is here, being seen that in spite of being a Saturday afternoon, you're still glued on your chairs. I know the lunch is being served, but still you're glued. That's a good part of it. I'm also thankful to esteemed academic dean, Dr. Arish Patak. He couldn't make it here, but is always there supporting all the academic ventures what we do at Seth GS Medical College and KEM Hospital. I also thank our medical superintendent, sir, Dr. Desai, sir, who came here, who shared his views on rabies also. And we would like to thank the entire team, our organizing chairperson, Dr. Vijay Singh, sir. Without his efforts and guidance and light bearer approach, we couldn't have done this event any better than this. Thank you so much again, sir. I would like to thank all my faculty who had taken out their valuable time and came here, sat here for a couple of hours, for 3 hours, to the entire CME, and they have extended all my support or extended all the support while I am doing this particular work, also managing my duties and where I was, filling in my shoes wherever it was needed. I extend special thank to Dr. Shrikala Acharya ma'am, who shared her day of seminar for this particular CME. I would want to special thank again And shout out to our favorite Swati ma'am to have graciously contributed to the welcome address. At the last moment, I asked her that, ma'am, will you be doing it? It was last moment. I asked her because I had belief in her that she would not say no to me. Thank you so much, ma'am, for your welcome address. I thank all the senior faculties from the Rukubhai. I thank all my senior faculty who have been here, being part of the program, as well as sharing their time, as well as giving, extending their hand towards giving the mementos away. As fantastic speakers from all the departments, we tried to make it multidisciplinary as we could. The topics were really holistic kind of a nature, wherein the medico-legal aspects of animal bite, something which we might not have heard of, also was included. So thanks for all the speakers who shared their experience, as well as made us engage in this particular speakers like Deepika before her also. They made us engaged into the CME. So thank you all. We also appreciate the most important support from Zydus, who extended their support, their academic partnership with us through this entire CME. I don't want to miss, outside don't want to miss the AV team. They have done an excellent job. Mind you, we are doing it physically here, but there are quite a few people. There are more than 80 people who are attending this particular CME online as well, on the Zoom as well as YouTube Live. Some of us who want to attend this, or maybe later on see this particular CME, it will be available on our RRC channel, which is regional network also. So that will be available on YouTube also. Some of you must have missed out, must have dozed off because of the AC, you got numbed. Yes, you can go there and watch it again. So CVTC Hall staff, again, for all the support which they have extended, Tara Chandai, food organizer Uday Shetty sir, cameraman Chakmeji, and our beloved Sachin sir, who's an artist, who extended his support towards making the beautiful banners and certificates as well. Thank you everybody, and my fabulous team out here. Shout out to Rosna, shout out to Maria, shout out to Rahul, everyone who's here. I can see Supriya, Shweta is here, and most important, Rutuja. In spite of her ill health, she's been here. And all your residents, this is what spirit of all residents is. You all live, you all make our, I can see too many rock, you all really rock. And you all are support, you are a huge support. And we have Dr. Satish Maya sir, who is an MMC observer. Thank you so much, sir, for taking out time. We welcome you. Yes. Maya sir was busy with his commitments at GS Medical, Topiwala National Medical, that's my alma mater, I forget that, sorry. Topiwala National Medical College and BYL Charitable Hospital. Thank you so much for your time, sir. My rights are supposed to be clapping a little harder. Yeah. Great. Thank you so much, sir. So, thank you so much, everybody who contributed to this particular CME being a success. I hope you had an academic fist, and any question which comes on rabies will be answered very well in your theoretical as well as practical parts. I'm not going to take an exam for now. Thank you so much. Thank you so much, everyone. Have a nice weekend. Thank you.
Sorry, I would like to request Dr. Vijay Kumar Singh, sir, to felicitate Organizing Secretary Dr. Raman. Thank you, everyone.
Lunch is outside. Announce kar do na Delhi.
Huh?
Lunch is outside.
Lunch is outside now. Kindly take your lunch and leave.
Lunch boxes are